Good afternoon, everybody. Are we
Good morning.
live? Oh, it is good morning, isn't it? I've been up since 4. How about you? Seems like it's afternoon. 3:45. You beat me. Welcome to Health Coverage Insurance and Financial Services. We have several work sessions. I believe we are 11 today that we are going to be hopefully working through. But before we start that, we'll start with introductions with Representative Chimino.
Thank you, Madam Chair. I'm Mary Grace Chimino. I represent House District 83, which includes the towns of Bridgeton, Harrison, and Denmark.
Welcome, everybody. I am Representative Poppy Arford. I hail from State House District 101, the western part of Brunswick.
Good morning, Representative Michelle Boyer. I represent House District 123, which is most of Cape Elizabeth.
Good morning. I'm Sally Clucci. I represent House District 52, which includes the communities of Bowdoin, Bowdenham, and Richmond.
Good morning. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Stamford in the village of Spring.
Good morning, everybody. Paul Flynn, House District 63, Winslow, Albion, Freedom, and Unity Plantation.
Good morning, I'm Rolf Olson, District 86, which is Raymond, Casco, Fire Island, and a bit of Poland.
Good morning, my name is Bob Foley. I represent House District 145, which is most of the town of Wells.
Good morning, I'm Donna Bailey. I represent Senate District 31, which is Buxton, Old Orchard Beach, and Saco. I serve as the Senate co-chair. I'm going to step away for a moment because I forgot my water bottle elsewhere. I'm going to go retrieve it. Be right back.
And good morning. My name is Christy Matheson. I represent District 151 in Kittery, and I serve as the House co-chair. We are going to go a little bit out of order. We're going to start with LD 2129.
Okay.
Colleen.
So I think you all had a chance to review the analysis, which is in your folder on blue. But I'll go through it quickly. LD 2129 is act to prohibit liens on principal residences and wage garnishments for medical debt. As it's drafted, it's intended to prohibit the placement of a lien on the principal place of residence of a consumer and prohibit the garnishment of salary or wages of a consumer when the related action is based on medical debt. Sections 1, 2, and 3 amend the Maine Consumer Credit Code to prohibit the enforcement of an order garnishing a consumer's wages based on medical debt or an execution of a lien on a consumer's place of residence. Section 4 makes a grammatical change. Section 5 is a provision that provides that a debtor's principal place of residence is exempt from attachment and execution based on medical debt. And Section 6 and 7 amend the Maine Fair Debt Collections Practices Act and prohibit a debt collector from initiating any action that attaches a consumer's principal place of residence or garnishes a consumer's salary or wages for a judgment in any action in which the claim against the consumer is based on medical debt. As the committee might recall, last session, you considered a bill LD 558, which was enacted as Public Law 2025, Chapter 201, which I attached for you. Under that law, a consumer reporting agency may not report debt from medical expenses on a consumer's consumer report. The law also prohibits a debt collector, debt buyer, or an entity that provides healthcare services from reporting medical debt to a consumer reporting agency. For the purposes of the law, it defines medical debt as debt arising from healthcare services, including dental services or healthcare goods, including products, devices, durable medical equipment, and prescription drugs. It excludes debt arising from services provided by a veterinarian, debt charged to a credit card unless the credit card is issued under an open-end or closed-end credit plan offered solely for the payment of health services. It excludes debt charged to home equity or general purpose line of credit, and it excludes secure debt. As LD 2129 is drafted, it adopts that definition of medical debt when by cross-reference. Some of the issues for the committee's consideration is, to the extent to which medical debt should be treated differently than other type of debt. As I mentioned, it defines medical debt as I just described, and it would exclude credit card debt or secured debt that may be used to pay medical bills or a home equity line of credit. It excludes that type of debt. It's just trying to narrowly focus on I guess, medical debt, specifically those bills that are generated from a healthcare provider or other healthcare entity. And you did have testimony from the Maine Bankers Association, neither for nor against, recommending that the committee do maintain that definition as currently written, which I think attempts to recognize the differences between solely medical debt and debt that is more general debt that could include some medical debt if you're using a credit card or other loan product to make those payments. You did have some testimony from the Maine Hospital Association, neither for nor against, suggesting that perhaps this legislation is unnecessary because hospital practices are already regulated under current law, and hospitals and other providers don't typically use these types of debt collection mechanisms. As drafted, the bill does not prohibit a hospital or other healthcare entity from billing for medical debt or negotiating payment plans, but it does seek to limit these two particular forms of enforcement for unpaid medical debt, the garnishment of wages and the lien on someone's principal place of residence. I do have a technical suggestion. If the committee moves forward, I would suggest amending Section 5 to not withstand a provision of current law that relates to attachment of a debtor's residence. Under that paragraph, there are certain monetary limits on the interest that is subject to attachment. And as drafted, LD 2129 appears intended to exempt all of a debtor's interest in their principal place of business from attachment if it's associated with medical debt. So just recognizing the differences between the new paragraph
Oh.
F that's added in
Oh, I
LD
see.
2129 and paragraph A, just notwithstanding that I think the intent is that paragraph F would control and there wouldn't be any sort of calculation of a certain amount of interest being excluded. So that's a technical suggestion. You did have some
Colleen,
information.
Quick
Sorry.
question.
Can you please say that again using different words?
At page 7 of the analysis, that is a copy of the current law that is amended by LD 2129, and LD 2129 would add a new paragraph F. And so under the existing law, there are provisions that exempt property from attachment and execution. And one of the categories is a debtor's residence. If you look at paragraph A, it only protects the debtor's aggregate interest not to exceed a certain amount of value in their home. And paragraph F, as I read it, if you're adding that to the statute, which is in the bill, would exempt all of a debtor's interest in their home from being attached for medical debt. So my suggestion is to make sure that there's no inconsistency between how the statute is read, you would amend paragraph A to say, except as provided in paragraph, you would amend paragraph F, to say at the beginning of paragraph F, notwithstanding paragraph A, all of a debtor's principal place of residence is protected from attachment.
For medical debt.
For medical
From
debt,
medical
right.
debt.
Understand the suggestion? Yeah.
Thank you
Kinda
so much. That
technical,
was
but
so
that's-
helpful.
That's what I'm suggesting. So. I think you need to do it, so if you
Okay.
move forward. And then the last thing is just,
Sorry,
oh,
Colleen.
sorry.
Yes, Representative Flynn.
Thank you. Thank you very much, Madam Chair. Colleen, quick question. Do we have any historical numbers, meaning how many Maine residents were subjected to actual attachment on real estate in any given calendar year?
We
For
don't
medical
have
debt?
any particular data now on that. I wasn't able to find anything particular, and if we did, it wouldn't be any distinguish, it wouldn't
Mhm.
distinguish between regular debt, whether it was for medical debt or other types of debt.
So we don't know if we're dealing with 400 or 400
Yeah,
cases. Thank
I
you.
don't think yeah. And you did have the testimony, I think, from the Hospital Association noting that from their perspective, they don't believe that they use the tool of, but it's more, I think if you moved forward with this, it'd be more of a proactive perhaps.
I would assume much of the collection then becomes, it's from the hospital, they've sold the debt to a debt collection agency at that point?
I think that happens, and the language of the bill both covers situations where it would be a individual hospital pursuing a consumer or a debt collector or debt buyer. Yeah, it would apply broadly.
Yep.
The sponsor had provided some information about other state laws, sort of generally how they approach medical debt. And I just, to sort of supplement that research, kind of outlined for you some of the states that have specifically taken action with regard to liens on residential property and wage garnishment. So you can see the outline of that. I mean, some states, as you can imagine, states all do it a little bit differently, you know, in terms of the specific language. But there are several states, including other states in New England, that have taken similar action as proposed in LD 2129. And then finally, the fiscal impact statement, the preliminary one you received from the Office of Fiscal and Program Review, indicates that this may decrease the number of civil suits filed in the court system. The judicial branch may realize some minor reductions of workload and administrative costs associated with the minimal number of cases that they expect may no longer be filed, and that the collection of filing fees may decrease general fund revenue by minor amounts. Because preliminarily, this indicates that any impact would be minor. I do expect that if the legislation moves forward, it would, even though it identifies a potential minor impact on the general fund, it would not be a bill, in my experience, that would be referred to the special appropriations table before it moves forward. And I'll stop there, and I'm happy to answer any questions you have.
Thank you, Colleen. Representative Boyer?
Thank you, Madam Chair. Thank you, Colleen. Colleen, where you list that 5 states provide partial protection and they somehow they tie it to qualification as low income.
Yeah.
Do you have more information on how they do that?
So it's typically, it's based on like a percentage of the FPL, which is, a percentage of their income. So if their income is at or below, a particular percentage. So, 100%, 200%, 400%, that's typically how they've done it. And it kind of ranges to how they identify it. I think, it would be a policy decision if you wanted to do something like that. You would look, most states, when they do something, they look at the sort of the general FPL and then do it as a percentage of that, above or below. Typically, a factor of, 2, 3, or 4. 200, 300, or 400 are most commonly the ones that I've seen.
Representative Olson?
Thank you, Madam Chair. I guess concern I have here is we have the potential now of setting up 2 classes of people. Those that have a lien against them already for medical debt, and now those that we would not have. Is there a way for us to at least freeze any ongoing interest on those that have a lien in existence? Because, if this were to go through, then, people, they're not going to have any interest added on there. So you've got, if at least we can freeze their interest at where it is right now, we lock what their debt is, that's the lien is against.
Meaning that there couldn't be any prospective accumulation of interest on that debt prospectively. I'd have to fiddle around with how to draft that, but I think you could probably, off the top of my head, I don't think I see any issue with that. I mean, you could put some language in there, authorizing the court, something like that, I think that's probably how you'd have to do it, like in the future. I don't know. I'm just thinking out loud about how to accomplish it, but I don't know that if you can't like retroactively go back and change the terms of the debt
Agreement, right?
But perhaps you could put some language in there that when those liens the property goes to be sold, and if there's a court action or something, you would only be subject to the interest that was accumulated as of a certain date.
Yeah.
But I think you'd have to authorize the court to do it, but I'm just thinking out loud.
I mean,
Senator Bailey?
Yeah, I think you'd have to put it in the writ of execution
Yeah.
title,
Yeah.
Title 14. And I think you could stop the accumulation of interest on any liens as of the effective date of the statute. Again, doing it prospectively. So I have confidence that you can figure out how to word that. So I think you could do that. My question is, there was a suggestion that perhaps we needed to add the statutory reference to medical debt to the two sections that don't have it currently. As I read it, Colleen, I don't think that's necessary because that's in the same section.
Yeah.
I just wanted you
Yes.
to confirm.
Oh, yes, yes.
that.
I don't believe you need to do that because for the purposes of section 6 and 7, medical debt is already defined for that act.
Okay.
So
thank-
we don't need to add the cross-reference
Okay,
there.
thank you.
Yeah.
That was
Yeah.
my understanding as
Yeah.
well.
Yep.
Additional questions for Colleen? Seeing none, what is the will of the committee? Senator Bailey?
So I'll make a motion to pass as amended with Colleen's technical amendment, adding the notwithstanding language as well as Representative Olson's suggestion about freezing the interest on any existing liens on principal residences.
Second. Any discussion? Seeing none, I think we're ready for the vote.
Thank you. Senator Bailey,
Yes.
Senator Bailey, yes. Representative Matheson,
Yes.
Representative Matheson, yes. Representative Alford,
Yes.
Representative Alford, yes. Representative Boyer,
Yes.
Representative Boyer, yes. Representative Shamino,
Yes.
Representative Shamino, yes. Representative Cochi,
Yes.
Representative Cochi, yes. Representative Flynn,
Yes.
Representative Flynn, yes. Representative Foley,
Yes.
Representative Foley, yes. Representative Mastracchio,
Yes.
Representative Mastracchio, yes. Representative Olson,
yes,
Representative Olson, yes. 10 members of the committee having voted in the affirmative and 0 in the negative.
Thank you. That was Anne Marie.
Oh, thank you. Yes, great. Thank you very much.
Thank you. So now we're going to open the work session at LD 2151. This is one we've worked a couple times.
We've been doing this a while.
Yeah.
So,
We're getting there.
and unfortunately, I don't think Senator
Yes,
Baldacci is here to update you on any discussions that he has had on LD 2151, but I can update you at least on my homework, which I think was to sort of take a look at and speak with the Office of Fiscal and Program Review about ways to kind of streamline the proposal to minimize the administrative resources that would have to be expended in making the grants and sort of explore ways to get the funding out in a more direct way to those FQHCs that are interested in receiving funding under the proposed appropriation of $4 million. And so the committee had asked for some initial information that indicated there were 8 FQHCs that were interested. You do have some updated information, as I understand it, from one additional FQHC that should be in your folder that came in from about an expansion from the Maine Mobile Health Program, which is associated with an FQHC. And so recognizing that and building on the discussion I had about how the committee might approach it, you have on the buff colored sheet a draft for discussion purposes. It would maintain the emergency, but instead of an allocated section of law, which would set up a grant process within the Department of Health and Human Services, this would direct DHHS to appropriate $4 million in one-time funding to expand retail pharmacy services in federally qualified health centers. It would require the funds to be granted equally to no more than 9 FQHCs that serve residents in rural and underserved areas to support the planning, designing, constructing, and expanding of one or more retail pharmacies. And that was sort of what the committee was focusing on, that sort of subparagraph 1 during your last discussion, because there were 3 different kind of categories or options, if you will, and you had focused on that one. You certainly could expand that, but you had focused on that. So that's what this proposal is focusing on as well. It would require the health centers to provide a proposal and a proposed budget prior to receiving funding. But again, the idea would be each FQHC up to 9 that submitted would get equal funding. So there'd be no sort of discretion. It would just be everybody would get the money that asked for it. It wouldn't be necessarily meet their budget, but it would contribute to the budget for their proposal. And it incorporates some of the existing language that was in the prior version of the bill, directing the department to implement a change in scope adjustment for FQHCs, which has to do with sort of their ongoing funding, as I understand it. So that's one way that the committee could do it in terms of, and it's modeled on some things that have been done in the past in budget bills and other legislation. The fiscal office recommended that if you did it this way, they thought that you could still keep the DHHS as the agency that would be responsible for expending the funds. You would have other options, but their suggestion to me was that because DHHS provides funding and FQHCs are associated with the department, they would have all the existing kind of infrastructure in place, the information that they would need to make the payments easily to FQHCs. If you transferred the responsibility to another agency, there may be some additional steps in terms of getting them, getting their proper information to sort of, getting them into the system to be able to remit funding to them. But it would be up to the committee as to whether or not you thought that, as in this version of the legislation, it would sort of minimize the resources that DHHS would need and sort of allow a more streamlined process and to meet the timelines that are contemplated. So that's something I think for the committee to consider. One thing I would note is the way this is currently drafted, it speaks to expansion of retail pharmacy services. I think if you move forward, given the proposal from the Maine Mobile Health Program, I think we might want to sort of tweak the language to include mobile delivery or something, just to make sure that you wouldn't be inadvertently excluding them from the language. But you could think about sort of, does this, is DHHS still the right place? The purpose, are the purposes correct? Is this the right timeline? I suggested no later than December 15th. That was kind of the timeline that was in the bill. You could certainly make changes to that as well. Yeah. But if you did the math, 4 million divided by 9, it would be like 444,000 per FQHC. It's not perfect. It's not perfect like 10 or 8, but the math, but a few extra cents, but they can round up from some of
Representative Cloutier.
Thank you, Madam Chair. So, Colleen, I had a conversation earlier today with the Maine Primary Care Association, and they apparently also have a vendor relationship with the state. And so I'm wondering if we do want to just excise DHHS from the process, if we could write the bill so that that money goes to them and they distribute it. Because the other question I had, just the way that this is written, it says that each FQHC will provide the department with a proposal prior to the receipt of funding. But would they choose to engage back and forth on that proposal, and could they set requirements or report backs or anything like that? I'm just curious as to.
Not the way this is written. It's intended to be, you have to have some trigger for how they get the money. And so that was just the and identification, because one of the things they cautioned from staying away from was identifying each individual FQHC by name in the statute. So you're saying they up to 9. So in order to make sure that all 9 want that, they would have to communicate with the department in some way. Once they did that, they would do that. I mean, you could streamline that. You could just say, wouldn't have to be that they have to give a proposal and a budget. You could just say each, FQHC could apply to the department disperses the money. I mean, you could modify that in some way. You also could, I think you could do the association. We just didn't have a discussion about, specifically about the association. I don't think that would be an issue, and have them disperse the money. Wouldn't have as much control, I guess, because it would just be a lump sum going to the association. But that's, if you did that, you might want to build in some report back or something from the association to the legislature about the, how the monies were dispersed. If it's going, in a lump sum, then off, as opposed to if it was DHHS doing it, you'd have a way to track those disbursements.
Okay, Representative Foley.
Thank you, Madam Chair. Colleen, should we have a date by which the department or whoever's going to get the money has to have the proposal? I mean, if we just, right now it just says they have to distribute the money December 15th, 2026. I mean, somebody could come in December 1st and say, oh, okay, I want to get in too. I mean, maybe we should say proposals received on or before July 1st or
Yeah,
something.
you certainly could do that. Yeah.
I mean, I just think that you want to prevent somebody from jumping in at the last
Yeah.
minute.
Yeah, I mean, you could certainly do that. This is limited to up to 9, so somebody couldn't jump in at the last minute and be number 10 and get funding. It would be,
Right.
the
And if
first
we're
9.
Distributing it equally,
And it's
they kind of
equally.
have to know what that
Yeah,
number is.
exactly.
It's a
Yeah.
good idea.
So, but you certainly could build in an additional timeline. That was something that was in the original bill. I think there was an original timeline, like 60 days before the department would get guidelines out, for instance. So you certainly could add another timeline, by September 1st, they submit, by December 1st, they disperse, or July, whatever you want. If this isn't an emergency, if it is an emergency, it's not an issue, but if it's not an emergency, the effective date would be generally sometime in July. So you might not, in case it's not going to be an I don't know, you might want to pick a date that it's going to be safe past 90 days past statutory adjournment, in other words.
Representative Olson.
Thank you, Madam Chair. Well, I guess there's probably two ways you could address that. You could always put in the language, you could put in within X number of days of the law being enacted.
Yeah.
And that way, it ties it there. But the other thing, as far as subbing it back out to another entity, you run the risk of them legitimately asking for some fee in order to administrate it. What we're trying to do is get the money into the hands of the FQHC. So any that we take away from that is hurting them at the same time. So I think we need to be a little cautious on how we look at that.
Representative Chimino.
Thank you, Madam Chair. Colleen, when they came up with that $4 million, do you know how many FQHCs they were basing that on?
I don't know if they did sort of the same calculus that the committee did in terms of interest. It was originally, when it was proposed to the committee, I think it was a higher amount. It was 7.5 million, and that was reduced in the appropriations process when it was first reported off of the appropriations table. So I think they just maintained that same 4 million, but I think the original ask to the HCIFS committee was 7.5 million.
Thank you. Do we know how much it costs to actually put a pharmacy into an existing FQHC?
Well, you did have some information that was shared prior to this work session from the FQHCs generally that sort of outlined some of the proposals. And I think the proposal that you had from Community Clinical Services, maybe that was the one in Lewiston, was talking about building out a pharmacy. And that had some budget in there. So if you look, I don't know if you can find it in your folder, but there was some paper clipped information there. This is sort of outlined the budgets from some of the proposals, and they modify. So that one, I think, talked about building out a small community-based pharmacy. They're the ones that are located in Lewiston. I think they had an estimated project cost of 750,000, but they would build out existing space that they had. I don't know if you went, you know, sort of constructing totally new. Let's see. So you might want to look at some of the others. I don't recall the specifics of some of the others, but the budgets you received ranged from. So you had one from Health Reach Community Health Center to submit for renovation and purchase to add an in-house pharmacy. That was 1 to 1.5 million. So I think they sort of ranged.
Representative Lucci.
Also, Eastport had said theirs was going to be opening a pharmacy at a new health center, which would have been a full startup, and their request was for 500,000. So one thought I had, just as we were talking about, you know, if we're not going to list the 9 by name, you know, we've got all people that have done the work and like generally seems pretty good to us. You know, there's like, I think, what, like 20 or more federally qualified health centers. So I wonder if we're going to set ourselves up for, then the department is going to have to make choices if more than 9 apply. And so if we are, you know, wanting to say the ones that have applied here are the ones, then I think we should try to be more directive, because otherwise I just worry that it's going to open DHHS up to having to make those decisions, and then that would slow the process down, because if there's 15 applicants.
So you could, the language now talks about up to 9 in rural and underserved areas. So it tries to sort of narrow it, but you could be more specific. You could do it by county. You know, you could be general, but be more specific without outright naming them. So you could do that if you were worried about that. So we could work on sort of narrowing it a little more. And I can reach back out and see if there's a way that you could identify them specifically. But when we originally talked about it, it was sort of describing them. And if you said the number and you said equally, that sort of like limited each thing you said sort of removed the discretion of the department.
Okay, further questions, Representative Mastracchio.
Thank you, Madam Chair. I guess I'm having trouble like saying that it's going to be equal when we've got a really reasonable proposal from the Maine Mobile Health program, which is 300,000. So I'm just, how do you word this so that they don't need 450,000. I'm not going to give them 450,000. I think there needs to be some place that, first of all, that it actually says what it is. It's basically seed money. We're not going to pay for the whole thing for some of them that want, you know, 1.5 million, and that has to be used for the establishment of a pharmacy, and that we need to hear back that they actually did that. And that is the problem with just handing money out and not seeing what they did with it. I mean, we learned that with ARPA money, and, you know, you hand out a lot of money and then in towns and counties, they figure out, well, what can we spend it on? It needs to be real clear what this is being spent for, and that we're not going to give somebody more money than they need just because we say we're going to do it equally. That's all. So how do you do that?
Up to, you could do up to,
Up
I mean, you
to.
could say up to or no more than equally, you know, FQHCs equally, you know, the 9, but up to a certain amount of money.
Can I
You
say-
certainly could do that. if
Right,
you
because I'm
wanted.
also concerned that they're going to just, you know, come in with their proposal and say, well, I want that equal amount. When they truly don't. I mean, I'm glad that we've got something in writing. I just, you know, I want to get the money out there and I want to do this. I just want to do it as efficiently and also be a good steward of the taxpayer money. So
Representative Lucci.
For the committee's consideration, what about, you know, saying that, you know, we would fund completely the amounts of the people who have applied up to, you know, that $444,000, they would get their full amount. The remaining amount would be divided equally among the remaining ones. And I do think we do definitely need to have a report back from the FQHCs about this for sure.
Representative Arthur.
Yeah, thank you, Madam Chair. It does seem like as we're getting into the weeds, it is becoming more complicated. And adding to that, there's no guarantee this will be funded at the $4 million level, correct? So we do run the risk of having this funded at a $3 or even a $2 million level. So I'm wondering if we want to come up with some sort of a formula for funding. So everybody's guaranteed of the 9, I don't know, depending on how much money we get. I don't know, maybe not a formula, but some way of not counting on the 4 million, not counting on everybody needing this $444,000 share when we divide it by 9. Well, my concern is really, we need to get this, we need to pass it. I fully support it. We need to get it to the committee, the EFA committee, and we need to get it there in a condition that they're going to want to fund it. It will make sense to them. It'll be clean, it'll be clear. And they understand that if they do fund it, the money's going to go out in a certain way. And I'm not sure if we're there yet. I don't think we're there yet,
No,
actually.
we're still discussing, but yeah, I think as far as the amount, I think, that doesn't have to be 4 million, but we do set an amount. That is not to say that AFA will not change that amount. They do it all the time. But then that will be in their hands in terms of how they do that. If they say, well, we're only going to do 3 million, and how they're going to change whatever we give them in order to accomplish that 3 million. So I don't think we should try to think of all those contingencies. So. Are there questions, comments? Representative Cucci?
And maybe we should raise the amount of money. To back to 7.5 million from when we were first talking about this, and that way AFA has a little bit more wiggle room to mess with us, but we still get what we want.
We can always do that. That's certainly possible. Yes. I did have a question. She's looking at her phone for Ms. Garrett Reed, just because Senator Baldacci is not here. Was he able to talk to you about the Office of Affordable Healthcare being the intermediary? Okay, thank you. I just figured I'd ask to have that information. So what is the committee thinking? Seems we should at least give Colleen an idea in terms of, do we want it to stay with the department, or the suggestion was made to have it run through PCA? Representative Clucci.
So I think I would prefer it to run through PCA. But I also I'm going to stand by my suggestion of funding all of the ones below the sort of equal amount request 100%, and then dividing the remainder amount equally. That's I think, and I think I think mentioning the organizations that applied, I think, is the way to do it. And Maine Primary Care Association has been working closely for the last couple of years with the FQHCs on this. And so I think we can ask them to give us a report back. That's what I would propose. And I would also maybe say increase the dollar amount.
To what amount?
I mean, to make it nice and clean, you could do 4.5 million, then it's 500,000, sort of available for each. But that doesn't matter, I guess, now, if I'm based on what I'm saying. So never mind, just that's what I'm gonna leave the money amount alone, but yeah.
Okay, Representative Arthur.
Thank you, Madam Chair, and I appreciate Representative Clucci's comments. And to follow up with them, if Maine Primary Care Association was sort of to become the administrator, how would that work? I'm actually not quite clear how they would do that. I can sort of understand how the department would do it, but how would they do that? Would they be would they be asked to make decisions? Because, okay. Okay, so we're setting up all that. They're just going to be administering it.
Correct.
But how are they I mean, I know they're an amazing organization, but how are they more qualified than potentially the department to administer this particular, which would be a new law?
Representative Coaching.
I would say that they've already been working closely for the last couple of years with the FQHCs on this specific issue. And so I think they're well versed in all of the specifics about all of the programs that want to be launched from the FQHCs. I think that they're the ones that have suggested that they'd be willing to distribute the money. I imagine that they're willing to do that without taking a fee. I'm seeing faces nodding in the audience, and so Rep. Olson, I appreciate your comment, because I think but I think if they're saying that they're not going to charge anything and they're just going to pass the money right on through, and then if we can hold them, that entity responsible for providing that report back to us, it's a little bit easier than having all the FQHCs do that sort of independently.
So I just need a couple more questions, and I like the idea. I'm not at all trying to be confrontational about this, but so the money let's say we get our $4 million allocated, the law passes, the governor signs it, and then the money is made available. And does the money go directly from the state to the 9 different entities, or does it would go to a federal call, the Maine Primary Care Association, and they would hold it, and then they would do the payout? So wherever that money went, that's a lot of money. It would have to sit somewhere between when it was allocated and when it was paid out. There would probably be some interest generated for a short period of time. I don't know how it would be managed, but in the end, someone's going to have to present us, I think, with a fiscal report of what happened with all this money, including if Maine Primary Care Association was the recipient of any of it for any reason and that type of thing. So I guess we're assuming that Maine Primary Care Association would not require any sort of an administrative fee, and I just wanted to confirm that. Okay. And they would be the entity reporting back to us, providing the report, as well as each entity themselves providing a report on what they've done with the money. The 9 different entities would provide a report. Is that correct?
Representative Matheson.
My suggestion would be that those FQACs would have conversations and reports that go to the primary department, and then they would put all of that information together and get that to the committee. That would be my suggestion.
Yeah, and but my thinking, that's a significant amount of report work and not being paid for it to do the report for all 9 entities. I'm just trying to really think about how this will actually work if we're going to go forward with this.
So from my perspective, this is a group that is really trying to help facilitate the FQHCs being able to serve more patients. It seems like this is work that they are already sort of contracted to do with the FQHCs to support the FQHCs and getting funding and growing and supporting the needs of the community. So I would imagine that they would be happy to do that work. And I'm seeing people nodding their heads, but
That's it for now.
Representative Foley?
Yeah, thank you, Madam Chair. I mean, I think there's a couple of things we could do. I mean, we could put in the bill that they distribute the money, but no administrative fees can be charged, something like that. But I think you could also maybe, whatever date we decide that the money has to go out by, you could have you could have the amount of money transferred to them 30 days before, or so that the state holds the money, and then when they're going to award it, say they're going to award it December 15th, the state shall transfer to this entity by November 15th, the amount of money to be distributed by, I mean, you could do it that way so that, yeah, they're not holding the money, the state is, but the state will disperse it. I think that might make mechanically a little better. That's a thought on that.
Yep. And just speaking of timing, did we kind of reach a consensus on when we wanted the proposals to be received. There was a suggestion of maybe a date. There was a suggestion of maybe being within so much time after the effective date. What is the committee thinking, just in terms of helping Colleen?
If we know
Redraft
it's gonna be an emergency, we can do it.
I
mean,
know.
That's the difference.
Yeah,
We
I
certainly
mean, because
don't.
you never know if the emergency will stand on that, you know, so
You
what I would say is within 45 days of the bill being enacted, the proposal must be there.
Okay,
That, because most of these already have, they've already submitted what they've got there.
Right.
So they're probably at the 90% level. They've got to do they probably have to do some polishing up and rechecking on things, but that also kind of stops someone that hadn't done anything from trying to jump in.
okay. Representative Arthur.
The place I think this is great. I'm definitely on board with what we're talking about, but the place I'm stuck with, it was my understanding that these entities, these 9 entities are the entities, even though we're not going to name them, that will be receiving some amount of this money. So if we were to allow other entities to apply, I'm not sure how, could we not just say these 9 entities are going to be receiving this round of funding, this round of one-time funding? Why, is there a reason we can't do that? Pardon?
Yeah, Colleen's gonna check up on that.
Okay, because to me, since they've applied, we've been discussing them, we know who they are, we're familiar with them, and they've done the work too of applying, that might make sense.
Yes, Representative Matheson.
So to kind of piggyback on what you were saying, Representative Foley, can we mirror this with how we do the state and federal shutdown bill where the money is distributed from the treasurer? Can the money just be distributed there and then it's maintained there, and then once a check needs to be written, it goes right out of the treasurer
Yeah, you could have the
since it needs to
appropriation,
stay?
have the association apply for the funds. Like Representative Foley would say, by a certain date, they request the funds and then the state controller transfers the funds or whatever. We could do it that way.
Great.
If you wanted to
So
remove DHHS from it, if that's what you're suggesting.
Right.
I think you do that.
So
Yeah.
I just want to be clear on what you were suggesting. Were you suggesting that the money goes directly from the treasury to the FQHCs, or it goes from the treasury
To
to
the association.
PCA? Okay,
Yeah,
thank you.
yeah.
Representative Clucci.
So now that it seems like we're getting to some consensus, I'm gonna throw out some other idea that just came to me that people are gonna not like. But what about instead of the general fund, what about other special revenue accounts?
Which account?
Which one?
Like the Bureau of Insurances?
Uh,
That had a whole lot of money to give to home repair and stuff,
I mean, for me, I am not opposed to using OSRs, but to me, there has to be some correlation between the OSR and what we're doing.
Mhm.
So,
I mean, I guess you could say by trying to fund the federal pharmacies at the federally qualified health centers, which are sort of nonprofits, low margin operating, businesses that in turn, that could potentially be saving money for insurers when people that do have insurance, commercial insurance that we regulate, are going to federally qualified health centers for their care. I bet Colleen could come up with a pathway.
Representative Boyer.
Thank you, Madam Chair. I just wanted to confirm, like, if we do the certain amount that's only going to go to pharmacies that can use that amount. Sorry, I don't know if I'm asking that correctly, but, ensuring that the funds will be used for the pharmacy, because, some of these are much higher than 444,000. do we feel like that language is in here or that's part of what?
Well, I
primary
think we
care
talked
would-
about making sure that maybe clarifying that they received up to, the maximum up to 100% of what they requested, not to exceed the equal amount. And then if there's any other excess, that would then be distributed equally. I think the language does specify the purposes for which it can be used. It could be certainly tightened up to say can only be used for these purposes or only for the purposes described in their proposal. Something like that to make sure that they're not using it for, you had a discussion last time about general operating expenses or salaries or something, if you wanted to exclude that type of thing, you could, we could make the language that's drafted here a little more explicit if that was important to you, for sure. Yeah.
And I think that's where requiring at least a proposal and budget
Yeah.
comes in, even though it's, not discretionary, but still to show that it's being used for these purposes, obviously. So. Further discussion. Representative Arford.
And this is just an operational question. Let's say we pass this, it gets funded, it works out extremely well, everybody's getting affordable medications, et cetera, et cetera. And then could this is a one-time funding, but this bill, this law will still be there, even, could it be refunded in future years, even though it says one-time funding?
Sure.
It could still be used as an instrument for
Could
funding
be
in the
put in a
future.
budget, and or, another bill to fund it could come
Okay.
forward. Yeah.
The only other thing I wanted to make sure I understood this properly. Well, I do think we should go ahead with the ones that have applied, because I'm not really understanding if we don't do that. And if we allow entities to apply now after we have put the bill forward and passed it and it's gone to AFA, then we will no longer have any say in who those entities are. And so then will the Maine Primary Care Association be the ones choosing the entities, or will every entity that apply get a certain, will they then divide it by like 12 entities? Excuse me.
Yeah, and that's why I think we are gonna see if we can list them
Yeah.
but it certainly is limited to up to 9.
Yeah, it's drafted to be only 9 can get it,
Right.
so it can't go beyond 9, but if we can specify the 9 that we know of in the law, we will do that. But
Okay.
that's generally something that's not permitted, so that's the thing I have to go double
Well,
check with.
because my
Yeah.
thinking is, if we don't do that, if we're not able to do that, then wouldn't we have to also set our own criteria for them? Because the Maine Primary Care Association then would be the one choosing the entities and how much they get, or just choosing the entities. Someone's going to have to be, if 12 apply and only 9.
Yeah.
So that opens up that whole other question of who selects and on what criteria
So
do they
we'll
select.
find out if we can
Yeah.
list them.
Okay, thank you.
So, anything else, Representative Matheson?
This committee loves letters. Is there any
We
way?
do.
Yeah, we love letters. Is there any way that we can send a letter to the Primary Care Association rather than trying to put it in statute?
So that would be the alternative. If you can't, you would send a letter saying our expectation is these are the ones you're gonna give the money to.
Yes.
So that would be the alternative. Yeah, absolutely. Yeah.
And or even some unallocated language.
Yeah,
in
well, that's what
addition.
this is. This is unallocated, but yeah.
Right.
Okay. Okay,
But- So that's why I think there might be some wiggle room because it's unallocated.
thank you. Think further. I'm assuming the committee, I don't know. I'm gonna ask, does the committee want to vote and deal with this on language review, or table it and have Colleen come back with a new draft, with what our consensus is?
Yeah.
What's the will of the committee?
I would prefer at this point to table it and have the actual language
Okay.
before us to vote on it.
Okay, is that a motion?
Move to table.
Seconded by Representative Mastracchio. All those in favor? That is unanimous. Thank you. And thank you, Colleen. There's always that one, isn't there? So, We do have Representative Kuhn now, so I think we'll open the work session on LD 2082.
So I don't have an analysis for 2082, but because Representative Kuhn asked that a revised amendment be shared, which was shared with the interested parties and the committee members ahead of the work session. It's on goldenrod. There's a lot of pages, but that's because the sections repeat, the same language repeats. But I can sort of highlight that for you, and there were some additional suggestions that were made that have not been incorporated in here that I can sort of highlight for you if the committee is interested. Suggestions for clarification and amendment. But generally, the amendment was intended to respond to some of the concerns and suggestions that were made at the public hearing. And they're sort of annotated, but if you look at section 1, some of the changes really are intended to correct some mistakes, but also to clarify that the scope of licensed professionals includes all categories of licensure under the following licensing boards if psychotherapy or behavioral health therapy is within their scope of practice. So it's intended to include the Board of Counseling Professionals, the Board of Social Work Licensure, Board of Alcohol and Drug Counselors, the State Board of Examiners of Psychologists, the Board of Licensure in Medicine, the Board of Osteopathic Licensure, and the Board of Nursing. And you'll see instead of naming, a licensed clinical psychologist or a licensed social worker, I've proposed defining a licensed professional by virtue of an individual license pursuant to the chapter under which they're licensed. So you'll see some repetition here because some professional counselors and clinical professional counselors are licensed under the same chapter. So you'll see those, they repeat, but I wanted you to see where you're sort of replacing that, the title with a cross-reference to the chapter. So you won't see the specific names listed, but it will be cross-referenced by the chapter because then it will pull in all the different categories of licensure under that chapter. So if there are, licensed social workers, there's licensed clinical social workers, there's different categories. There are some social worker conditional licenses, different. So by just referring to a licensed social worker, you may not be capturing all of them. And I think the intent of the sponsor was to capture those under the definition. So that's where you'll see, that's the approach there. And if the committee moves forward, you won't need to refer to chapter 119 like 3 different times. And only, I'll clean that up, but that's the idea. So anyone within these licensing boards that has this ability to, within their scope of practice, to provide psychotherapy or behavioral health therapy would be the ones that could, when we go on to section 2, could use artificial intelligence in supportive ways within these parameters. But under section 1 of the bill, this is the provision that prohibits anyone who's not a licensed professional from using AI if you look at page 4, the substantive provision is here, and it says a person may not provide, advertise, or otherwise offer therapy or psychotherapy services, including through the use of AI, to the public unless the services are provided by a licensed professional. So that's where the definition of a licensed professional comes in. And then this general prohibition would apply, and if someone violates it, it would be subject to a violation of the Maine Unfair Trade Practices Act. So that's the change. One of the things I wanted to note that isn't included here is you did have some suggestions at the public hearing that the definition of therapy or psychotherapy services may be too broad, because if you look at page 3, that definition there describes it as services provided to diagnose, treat, or improve an individual's mental health or behavioral health. There were some concerns that last clause, improve an individual's mental health or behavioral health, didn't account for You had some suggestions from health insurance carriers that it didn't account for
wellness.
certain apps or certain care management tools that they use, that you needed to have some clarifying language that it didn't apply in those situations. And I think there's been some concern about, you know, carving out, you know, a referral, whether it's through, you know, the internet or an app to certain educational resources about mental health, you know, that you're not pulling them in to this definition and making someone that app or someone who operates that app subject to this potential violation. So that's something that isn't clarified specifically in Representative Coon's amendment, but I just wanted to raise it for the committee's consideration. There were different suggestions about how to do it. One was to, you know, clarify that it's, you know, therapy or psychotherapy services means services provided to diagnose, treat, or improve an individual's mental health or behavioral health, and sort of pulling in there's a specific definition of therapeutic communication, like tying it to sort of a communication back and forth. You're not just reaching an app like, you know, the mindfulness apps, what some of the suggestions that came up for the committee, like, you know, they're a Calm or, you know, those sorts of things that people would just use as a resource, but not as a therapeutic resource, I guess. And those were the concerns some of the concerns you heard from folks who testified. And then the further concerns about excluding some of the things that are used by health insurance carriers for care management or things that are available through their platforms. The rest of the language in the amendment, just to highlight for you, is it does remove an exception, which was suggested by proponents of the bill, that would have carved out AI-based interventions. And that the first one is on page 5. It's paragraph B here. That would be through pilot projects administered by CMS, demonstration waivers or innovation models conducted in compliance with federal laws and regulation. There was some concern that that might impact some existing programs. And then when you look at sections 2 to 8, we did add a new section that was missing just to capture a licensing category that we missed. You'll see all of this language repeats, but we wanted to do 2 things. Clarify that the use of artificial intelligence by a licensed professional is limited to the administrative or supplementary support services, and those are defined in the bill. And also clarifying, the issue came up about HIPAA compliance. And so if you look at page 7, at the bottom of page 7, that change is made throughout all of the sections, clarifying that any use of artificial intelligence technology must comply with all state and federal confidentiality and privacy laws. There already was a provision requiring that the individual licensed professional comply with all of those laws. But there was some concern that if they were purchasing certain technology, that the technology they purchased also would be HIPAA compliant. That clarifies that.
Representative Matheson. Thank you.
Can you clarify if a provider is using ChatGPT to rewrite their notes, that's not HIPAA compliant. So what AI platforms are HIPAA compliant? I guess I'm confused about that. I mean, I'm not concerned about that being in there, but I'm just,
I think there was
Curious.
a concern that, well, as I had heard it explained at the public hearing, was that the individual person should be responsible for making sure that they're complying with that and complying with HIPAA, including, if
The
you purchase like a
provider is
medical
complying.
record, if you purchase like a electronic medical record platform, my understanding is that's supposed to be HIPAA
Yep.
compliant. So I think that's what this is intended to get at. But if it needs to be clarified further, we certainly can do it. But I think the intent is to say that the individual licensed professional is responsible. If the language of the bill already said that they're responsible for complying with all state and federal confidentiality laws, and it was broadly drafted to include HIPAA and then, and other things as well. So this language was just trying to pull in that technology piece. If it needs to be clarified further, we can certainly do that. Yeah, it's my understanding. And then the other substantive change I would note for you, the first place you'll see it is at the top of page 8. In all of the sections, we've added language stating that a violation is subject to disciplinary action by the board. And it cross-references an existing provision in Title 10 that sort of lays out all of the potential discipline that a board can take for a violation of licensing provisions. So it could be, could be a denial of a suspension of a license, a denial, issuance of certain sanctions, but those are all currently laid out in Title 10, Section 8003, subsection 5, and subsection 5A. So there's 2 different sections. They're consistent, but one subsection applies to the licensing boards that are overseen by OPOR. And the other provision relates to the affiliated licensing boards like the Board of Licensure in Medicine and the Board of Osteopathic Licensure. So depending on which section which chapter of the Title 32 we're amending, it will cross-reference either subsection 5 or subsection 5A.
So just to, again, clarify, so it sounds like the amendment is saying that if an unlicensed person uses AI to conduct psychotherapy, and I'm paraphrasing, obviously, it's an unfair trade practice. But if a licensed professional uses AI in violation, if we pass this law, it's just a licensing violation, so to speak, and there's no unfair trade practice and there's no private cause of action if harm befalls the patient because of it. Is that?
That would be how it would work. I think you could certainly, and it also would give the licensing board the jurisdiction over those complaints. You could certainly provide additional remedies if you wanted to, but yeah.
Okay.
Yep.
Thank you. Okay, go ahead. Oh, Representative Arford.
Thank you, Madam Chair. How would the board, okay, so a patient can fill out a complaint against a provider and submit it to a board. I already know that. Is there any other mechanism for the board to determine that a violation has occurred?
So I think the same mechanisms that currently allow it, the board could receive complaints not just from an individual patient. They could receive complaints from other licensed professionals, other folks can make a complaint to a board or bring something to a board's attention. I don't think it's limited to only an individual client or patient of the professional. So they could receive inquiries or complaints from other entities as well. It's not limited, and this wouldn't change the current ability of a board to receive complaints.
So, and I know we can't answer this right now, but it's something I'm pondering. How would anybody really know if a violation had occurred?
So licensing actions, sanctions, discipline, my understanding is those are public records that are available through the licensing board. So it would be available on their websites if any
No.
action was taken. Is that what you mean?
No, excuse
Oh.
me, I apologize. I'm talking about a violation occurs and how would they know? How would the patient know that a violation had occurred if this passes into law of the components of this law? Or how would another person know if a violation had occurred? How would anybody even know?
Well, I think there would have to be a knowledge, there are provisions in here for consent. So, a patient would be notified by a provider if they are using these services there are requirements that, for instance, if they're going to transcribe or record a session, there are specific requirements for a patient to provide consent to the use of artificial intelligence. So the individual, as I understand it, would be on notice that it's being used. And there are, again, certain prohibitions on how they could use it. But if a client or patient did not want to have the professional use these services, they could not provide their consent. So I think that provides the sort of notice.
Mhm.
And then if they felt that it went beyond what they were comfortable with, they would have an opportunity to make a complaint.
Is there anything in here, Colleen, if a patient does not offer consent, that, is there anything that protects them from not receiving treatment based on that consent? Like does that make sense?
Meaning-
I'm just concerned that if a patient says, no, I don't consent to that, then they're seeing a mental health provider, they're in a situation where they obviously are wanting to continue to see that provider, but can the provider say, is there anything in here that stops them from saying, I won't treat you because you don't do the consent?
Not explicitly.
Okay.
But I think that could certainly be something that you could do. It does say that a person licensed under this chapter may use artificial intelligence only to the extent that the use meets the requirements of subsection 3, and that's the consent provision.
Okay.
So, and then it has prohibitions on, you can't use AI to make independent decisions, directly interact in your therapeutic communication with a client. And you can't use AI to generate therapeutic recommendations without review and approval. So
Okay.
but I think if you wanted to sort of preserve the ability of someone to say, if a patient says no, they're still entitled to continued treatment, you could probably put something in there to clarify that.
Great.
Yeah.
Thank you, Representative Boyer.
Thank you, Madam Chair. Colleen, I think I'm getting a little lost in this conversation, but it's just supplementary support and administrative support that we're talking about, right? It's not therapeutic communication.
Yes,
So these are very limited tasks
yes,
that would be available.
yes.
Okay, so it's not, it's simply these like 6 tasks.
If you look at the definition, yeah, and they're both terms are defined. So administrative support and supplementary support. Yep. And so if you're the first time, I think it's not stricken out, but on the middle of page 5, top of page 6, those are the defined terms. And so that those describe sort of how the tasks that AI can be used for. The administrative support and the supplementary support. Yes.
Okay. Thank you.
Yeah, Representative Hartford.
Thank you, Madam Chair. And I really want to thank our analysts for doing such an amazing job of trying to interpret this for us. So when I look at on page 8, and it may have been before this as well, under definitions, the definition of administrative support, I'm just curious why it says, but is not limited to, which opens it up to things that are not listed here, obviously. So that's one thing. Is there a reason why it's not limited to those things? And then the other question I have is processing, billing, and insurance claims. Does that include, for instance, AI being used as a tool to scan through the notes to determine what codes should be used for billing? Is that, for instance, how that would work there? I'm not really, I have no idea how that would
Yeah,
work.
I mean, it could. I mean, I think the definition, really the substantive definition of administrative support is in the first sentence.
Mhm.
Tasks performed to assist the licensed professional in delivery of services that doesn't include therapeutic communication. And the administrative support includes, but is not limited to, is really intended as examples of the kind of things. So it's, it's not describing all of the tasks that are performed, but it's just an example. So that's why it sort of has the includes but not limited to. if you wanted it to only include those things, you could certainly specify that it only includes those things. With regard to the processing, billing and, processing, billing and insurance claims, it could be that it helps to identify the codes based on the notes. It could be that it sort of helps, fill out the claim form, it could be, I think, I don't read it as, being anything, too prescriptive there, I guess. But I don't know, haven't used these products, so I don't know the specifics, of how
Right.
they would be used, yeah.
I think that, again, there's the general description and then some examples, because of course, if we're gonna pass this law, you want it to live into the future, and we don't know, what AI is gonna be used for administrative tasks, for example, in the future. I mean, we have some idea of what it's being used for now, but,
Well,
you just
so-
can't predict these things.
Right. I'm only bringing this up because we have a relatively recent example where, and I don't have any idea if AI was involved in this, but it was a software program was used by a Medicare Advantage plan. Well, to go through the billing records here in Maine, licensed here in Maine, and there was a significant amount of fraud going on. They ended up being fined $22 million by CMS. It was a really big deal. And what they did was they took this software and they ran all their at least some of their medical records through it. And they created new billing codes that the provider themselves had not attached to the medical record. And they billed for these new medical codes. It was complete fraud. And I'm just saying, if we're going to allow AI to be used in billing, generating medical codes, honestly, there's no one, by the way, this whole fraud that happened here in Maine, I just don't want to mention names. I don't think that's proper in a public hearing like that. I mean, in a work session, but it was the reason the government found out about it was because of a whistleblower. If they hadn't had a whistleblower, it might still be going on to the tune of millions of dollars of fraud and so how are we going to, I'm just not seeing where the protection is in this for not just the patient, but the payer. The entities is paying the bills that are coded by potentially some sort of AI generated tool.
So I don't think Colleen's gotten there yet, but, I think part of the discussion we do have to have today
Yeah.
is the responsibility of the treatment provider, not just for violations, but for errors. And so, for example, if they're using it to do coding and it's improper coding, how is the treatment provider held accountable for those errors? I know initially there was some language just saying, generically, they're held responsible, but that certainly, I think, is a discussion to be had by the committee. Because I think that's the biggest concern, is not that the treatment providers are going to use AI in these roles, these administrative roles, these supportive roles. But if they do, and that AI makes errors, which I think we've all seen, our experience with AI is does make a lot of mistakes. And it's not perfect, but yeah, how do we make sure that treatment provider is held responsible for those errors? Whether it's an error that hurts a patient, whether it's an error that, again, makes mistakes in insurance claims, just so.
Yeah, and I would say this doesn't affect the ability of an insurer or a main care or anybody from, using their existing authority to investigate fraud or to audit or to, make sure that those errors aren't being made in sort of billing. So this is really just the
But the question, Colleen, is
Yeah.
do our existing definitions cover that?
Right, and so that's the
Because-
question, yeah,
Because I
yeah,
don't,
yeah. Yeah.
you know, I'm assuming a treatment provider that's using AI to do their bill coding.
Yep.
Just
Mhm.
Yeah.
to use that example, that if the AI makes an error, I don't know that that's fraud, right?
No, but when you talked about, you remember your discussion about LD 1301, which was talking about the use of AI for prior authorization and things like
Yeah.
that, and the Bureau of Insurance said their interpretation of the statute was that the individual, person is responsible, whether they're using AI or they're not, and so they felt like their existing statutory authority that they had was enough to hold someone responsible for the use of AI. And whether they were doing it sort of human, as a human. So I think, I think that's at least their perspective in terms of, whether it's AI or whether they're using AI or not, that they are looking at the responsibility is to the of the entity. And so I think that's one thing, sort of thinking about, the application of other provisions of statute, whether it's the insurance code or whether it's main care or anything like that. When it comes to, so I think that the responsibility of someone for those functions and mechanisms may already be addressed in law. Where it's not, I guess, is where you were talking about a specific error that might result in harm to an individual. That would be the thing that might not be addressed specifically in statute, although I don't think anybody would be prohibited from using existing provisions of statute, bringing an action, toward action or something against a professional if they thought that they were harmed some way by their use of AI, just like they could bring any action, they were harmed by their negligence in any other way.
Right, it would be a negligence standard. And so the question then is if we pass this, are we kind of setting the standard
Right.
for, meeting that threshold in a negligence case? Or can we be more specific?
Well, that's not, yeah.
Exactly. Representative Arford.
Thank you, Madam Chair. I apologize if I should be remembering and I don't. If anybody did testify during the public hearing as to how AI is currently being used, even if it's just in a rudimentary way in relationship to billing, if it is currently being used. I don't know if anybody testified about that. And if they did, I would like to be directed to that test. I'd like to read further about how it may be operating currently in Maine or may not be operating. Does anybody remember?
I don't remember specifically as to billing.
No, I
but-
don't think we heard anything specific to billing. It was more focused on notes, and note taking and assistance in sort of the charts and that stuff that we heard most of the testimony on, as opposed to the specifics of the billing and claims process. So I don't recall that we had anything specific, although you did have, the testimony you did receive from health insurance carriers was concern about sort of maintaining their ability to use their own processes, that this wasn't encroaching on that, but it wasn't from the perspective of the professionals themselves. I think we didn't hear any testimony on that.
Well, if we vote on this bill today, that's one thing. If we don't, I'd be interested in knowing a little bit more about that, about whether or not it's currently being used for billing, specifically coding and billing purposes, and how it's currently being used.
All right, I don't know where you were at, Colleen. Were you done or?
Done.
Okay.
I think I was done outlining the statutory sections, because it's all repeats, and I'd gotten to discipline, which I think is the end.
Okay,
Pretty close to the end, so, everything is intended to sort of repeat the same, make the same changes, make the same clarifications, and account for, each of the licensing chapters that they would apply to, so I think I was done.
okay. Any further questions for Colleen? Representative Clucci.
Thanks, Madam Chair. So I had a note that we had testimony from Cigna saying that they supported the intent, but they wanted an amendment to ensure that the low-risk wellness tools remain allowed. Can you tell me, like, can you help me understand where that is? Because I was trying to find in the bill, like, where are we talking about, like, tools versus like people?
Yeah, I think their amendment's not incorporated in Representative Coons yet.
Okay.
If you wanted
No,
to,
I don't
but
want to.
but if you,
Trying to
I
understand.
think where would be, I think it was two places. One is in that definition where I was talking about the definition of what therapy or psychotherapy services is. I think part of their concern was, that if you look on page 3, the definition talks about services provided to diagnose and treat. I think that's clear, diagnose and treat, but the improve an individual's mental health or behavioral health, that phrase, I think caused some concern from folks about that might reach into those sort of app-based mindfulness or wellness tools, whether it's an app or whether it's something through a carrier's website. So that was one place. And then they had also suggested some additional language that, this section is not intended to apply to or be construed to affect a carrier's, utilization or care management provisions. And I don't have their full language in front of me, but so it'd be, I think, if you went with a change based on their suggestion, it would be, I think, amending the definition of therapy or psychotherapy services, and then maybe also including some language that, someone doesn't violate this general prohibition if they're doing these things, and describing the tools that they want to preserve their ability to use, which I think they refer to like utilization management, care management practices, and one other thing. I could find it in my folder, but that's where I think it would be if you wanted to make that change. That would be the place.
Do we know if all of these kind of wellness tools and apps, do they charge? Are those fee-based? I
think sometimes.
don't think from the carriers that they are.
Oh, yeah, no, some of the apps, my understanding is, they offer sort of a free version, and then if
Okay.
you want to go further, there's
Continue.
sort of premium versions.
Okay.
They have some that are like
So that won't be an easy fix.
like a mindfulness. Yeah.
I was
So that's
thinking,
my
for a
understanding
fee,
of
yeah.
like some of the app-based things, like my daughter uses one at night, to help her get to sleep,
Sleep.
that sort of thing.
Yep.
Like, I
Yep.
think you can get a free version, but you could get like an extra version that,
Okay.
plays your variations of your, music.
Okay. Further questions? So discussion. What are people thinking? It's a lot. I will say that my overall concern is I'd like to see some more. I think everyone on this committee kind of knows I'm all about consumer protection. So in this case, it would be patient protection, just in terms of the consent. I don't know if I'm comfortable with just oral consent, because I think that can lead to a lot of misunderstandings in terms of, was that a yes? Did we really talk about that? And if the only place, that's reflected is the oral consent is through notes that are generated by AI, it just gets really weird. So I that's one thought I was having. Another thought, and these are just being thrown out for discussion, just to clarify that, is whether a refusal of a patient to consent to the use of AI can be the sole basis for refusing to treat a patient. That seems a little heavy-handed. Wonder if we need to put in here that any waiver by consumer of the provisions in these chapters is contrary to public policy and void and unenforceable. So make sure that providers aren't getting consumers to waive any of these protections. I think we've talked about patient privacy. I'm still struggling with something that I brought up in the public hearing, which was, again, how to ensure that a provider is held responsible for errors caused by AI. I think I talked about, for example, if they're using them for note-taking and there's an error in the note-taking generated by AI that then leads the provider to come up with a treatment plan that is based on that error. But also I got to thinking about, so that's kind of a direct consequence and potential harm to the consumer. But then I got to thinking about collateral consequences because in the world I live in, sometimes information from healthcare providers and treatment providers in these settings are used in court cases, especially child custody cases, but in general, and they're certainly used by the Department of Health and Human Services. And so again, if someone, going to give an extreme example, loses custody of their child either to the department or to the other parent based on something that was found in a treatment provider's notes or diagnosis that was, again, based on an error from AI that the treatment provider failed to pick up on, and they have that collateral consequence. Is there enough in here protecting that person to be able to remedy that and or go after the provider? That's kind of been my focus, is I think I'd like to see some more, I'm calling them consumer protections, patient protections. But obviously Colleen also raised some other issues for discussion. So Representative Arford.
Thank you, Madam Chair, and thank you for that summary, which I am very much in support of. But one thing I'm not clear on, I think that we have not yet determined whether or not there is any rule or anywhere or law that requires if a mental health provider or any healthcare provider for that matter has some form of a consent to treat document. In this case, it could be just in relationship to AI and how they're using AI. Is there any current law that currently allows that healthcare provider to deny care if the person is not willing to sign it? I'm thinking, the consent to treat documents that we all sign every time we start a new relationship with a provider. And I'm not sure how those are managed. It would be good to understand how those are managed, because really how this would be managed would be, I would think, somewhat in line with that. Does that make sense to anybody else but me? If we were to find, I'm guessing it's relatively easy to determine whether or not currently patients are required to sign the current consent to treat documents, which include paying their bill and releasing, it includes everything. And every provider's office gives them to every as far as I know, every time I've been to one as a new patient, I've been asked to sign it. So I would like to know currently if there's any law that allows a provider to require signing that. And if there is, I want to make sure that that law does not translate into whatever documents the licensed professionals that we're talking about in this bill that would allow them to also require a patient to sign any form of a consent to treat document.
Yeah.
They could, like you were saying, would not,
Yeah,
they'd be able to deny
I think
services.
Colleen can find out if there's any statute. I guess
Yeah.
the other question would be, if it's not in statute, is it in rule? Which kind of also leads me to think about, there's nothing in here about any rulemaking by any of the boards around this, correct?
Not specifically, not a shall adopt rules. They would have general rulemaking authority
Right.
that would apply, but there's not a specific rulemaking. I guess I would say with regard to this, the way this language is drafted, I interpreted it as to require a specific consent to this. So a general sort of consent form wouldn't satisfy in this situation because this is, requires that there be specific written disclosure of to the patient of how they would use AI, and then they can consent in writing or verbally. That was one of the changes that was made. So I think it couldn't, just a general, consent, I don't think would satisfy this, but I can certainly follow up on, if there are any specific consequences now, if somebody doesn't provide consent, what can a provider do and what their responsibilities are? Yeah.
Okay, thank you. Further discussion. You're looking quizzical, Representative Matheson.
I just, as a provider, I've never seen a patient if I didn't have a consent to treat them. And
Oh,
so.
no, I think you'd
okay.
have to have that, but you'd also have to have a separate one for this
Okay,
is what I
all right,
meant. I'm
all right,
sorry.
thank
Yeah,
you.
I'm sorry. That's what I meant. I
Thank
think
you.
you'd have to have something more specific than that.
Like, all right.
Representative Arthur.
And I don't want to get too far into the weeds, but this is complex. So then in that case, we would want to ensure like these larger entities that would operate in our state that might offer a number of different types of healthcare services, including mental health services, where you would have licensed professionals working for them, that whatever consent to treat document they require, that they don't put this in with it. In other words, that this would always have to be a standalone consent to treat.
Yep. Yeah, I see what you're saying. You don't want
Yeah.
it to just be kind of buried in.
Yeah.
amongst the
Exactly.
general.
You could specify that it'd be a separate document.
I would, I mean, I'll be honest. I mean, there's a lot of forms that patients have to fill out. And so this does, as a provider, I would put it in the consent. That would be my go-to, and that would be most providers' go-to, because you don't want to, if you want to fill out my new patient paperwork and tell me whether or not you want another form, I'd like to know, honestly. So I don't personally support this being a separate one, but I'm just putting that out there.
Can I just say this one thing? I totally, as a matter of fact, I am personally guilty sometimes of not filling out all the paperwork because a new patient, it is onerous. However, we're talking about a whole new field of technology, and we're trying to figure out a way to protect patients. And at the very least, notifying them that they will be, their record, in this case, their administrative records or billing or whatever, may be managed or not managed, but administered in some shape, way, or form by AI technology. How else will we know that they're being told that if they don't have to sign on some dotted line that they're being told?
Absolutely. That has to be clarified. I just, yes, I agree with you. They need to be told and they need to sign off for sure.
Can I just say, I understand where you're going with this, Madam Chair. I do, but in the big consent to treat document, it includes a lot of things that people have talked to me, like release of certain parts of their medical record. There may be parts of that consent to treat document they don't want to sign, not this. So, or it may just be this, and because they don't want to sign this, all of a sudden they're in jeopardy of maybe not being able to be treated. I don't know what the rules are, so that's all I'll say about that.
Representative Mastracchio, I think you had your hand up first.
Yeah, I guess I'm thinking, I'm a patient. I know how I am. Yeah, okay. And I sign. Sorry, but 99% of the people are just going to sign. You're at your person who you're supposed to trust. So I guess I get, when I went the last time, I got I'm going to use blah, blah, blah. Do you have any problems with it? And I went, no, whatever makes your life easier so that I can talk to you and not have you doing this, right? It's about patient care. So I guess I don't want to put any more things on the provider than we have to. I guess I feel like we're just really talking this to death, and there's a point at which we gotta, well, I'm sorry, but you're gonna ask people stuff that they don't even understand. I mean, we're having a hard time with it here. We're trying to protect consumers. Let's just figure out how we can do that and not make life harder for everybody else. I'm thinking about me in the office and going to an office and you have to get there 20 minutes early just to fill out, and then you don't even finish it because there's so much there. And they ask you to do it on your portal ahead of time too, but they still want you to do it. I mean, I'm just like, how does that protect anybody? Because you don't even read it till you have a problem. Sorry.
As a lawyer, I do read it, but just saying. Representative Chimino.
Thank you. I'm just thinking maybe if it's on the same consent form, that it's on a line where it has to be initialed. Because at least that way you know that they looked at it, they initialed it separately, and then you can still do it on the same consent form.
Thank you. Representative Cloutier.
So, as we're thinking through all of this, I worry a little bit about trying to define exactly how people can and can't use it. I sort of do want to be able to defer to people's professional judgments as to how they use new technology. And so, I don't know, based on our discussion, stop it. Based on our discussion.
Can you
Do a
repeat those
favor, will you
words?
repeat that?
I'm sorry. Just kidding.
So I don't want to hamstring providers. I want people to be able to use their professional judgment. I do think it's really important that people know how AI is being used and whether or not their personal information is going into some sort of an unregulated cloud. So, I mean, this is all really hard to understand and really complicated. And there's lots of sections. Those are the things that are important to me. That the provider explains, here's how I'm going to use the AI. And I just want you to know when I'm taking your notes, it's not going into the cloud somewhere so that, Bill Gates can take it and, take that information and, sell it to whoever, give it to whoever, to target you for advertising or persecution or whatever. Right? So especially if people are talking about their feelings and their beliefs. And this is all sensitive information that could be used for bad things. And so I think to me, those are the most important pieces. And I don't exactly know how we get there, but
Further discussion. Representative Foley.
Thank you, Madam Chair. I think through this whole discussion, we've given Colleen a whole lot of stuff to do. And I'm not really sure at this point in time that I would be comfortable until I see all those things that we've asked her to do. And so I think it's probably time to table this and let her come back to us with.
Could you just hold off on a motion just to make?
I will hold off on that. but
Thank you.
That's my.
Just to make sure there
thought.
isn't anything else or further discussion so that Colleen has a clearer picture. So Representative Arford.
No, I was just gonna second the tabling.
Okay, okay.
Sorry.
I just wanted to give people
Yeah,
a last
I-
opportunity.
Oh, yeah, and I'll have a question too.
Okay, great. Thank you. Representative Boyer.
Thank you, Madam Chair. I just want to make sure that in all this discussion, I don't know that we talked about further defining or not therapy or psychotherapy services. So are we going to try and
I
have
think-
that discussion now? Or are we going to ask
Put
you to
some
do
language in
more?
there for you to react to. Sounds like you'd like to see it, and then you can decide whether or not you want to include it.
Yeah,
Okay.
I think
Yeah.
there is consensus that we're
Yeah.
not trying to capture,
Right,
the yoga app.
right.
But how we do that is.
Yeah, and I
challenging.
think probably the way is to sort of tie it back to therapeutic communication, that if it's not, it's more like the interaction, I guess. So I'll look at, that's one of the suggestions was sort of focusing on, as long as it's not used for therapeutic communication, and then maybe carving some things out. So Cigna had suggested some language and there are some other suggested amendments, so I can look at that and bring something back to you to carve that out. So I think I would have included that in a draft.
Yeah.
And I guess the other question I had was if there was anything other than what Senator Bailey had suggested in terms of building or enhancing the consumer protections, if there's anything else that the committee members would want to see in terms of amendments. We've talked about the consent issue and the other things I've got here.
Yeah, and I think there seemed to be general consensus on Representative Chimino's suggestion as far as making it an initial.
That's all I was gonna
say.
Okay.
I
Yeah.
liked Rep. Chimina's addition.
Yeah.
Yeah. Okay.
She's not here to get credit, but we'll let her know. Anything else? Yeah, Representative Mr. Matheson, sorry.
Thank you, Senator Boyer.
I like it.
I just wanted to make sure that Colleen spoke with the sponsor if there's anything else that she needed to add to that. Okay, great.
Okay. Yes, I'm sure she has ideas as well. Yes, she's been taking copious notes, so. Anything further? Now entertain that motion. Representative.
Make a motion to table.
Okay, and is there a second? Seconded by Representative Arford. All those in favor? All right, thank you. Good work. Yes, yeah. All right. Well, so we have two bills that I think there's probably agreement to vote ought not to pass, so we're thinking we would do those two and then break for lunch. If that's okay with the committee, okay? So the first one is LD 2190. And again, let's see if I can find that. I know you had combined that, but I think we can wait until we do the other one to do the analysis.
Oh, yeah, sure.
Yep.
Anything you want to do?
So LD, open the work session, LD 2190, and I would entertain a motion. Representative Mastracchio,
Thank you, Madam Chair. I'll move on not to pass on 2190.
seconded by Representative Foley. Discussion. Seeing none, I think we're all set. Edna?
Yeah. Senator Bailey?
Yes.
Senator Bailey, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Chimino?
Yes.
Representative Chimino, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 8 members of the committee having voted in the affirmative and 0 in the negative.
All right, thank you, Edna. And then we'll now open the work session on LD 2199. Let's get there. Again, I don't think you need to do the analysis, Colleen. If someone wants to make a motion, Representative Foley,
Make a motion ought not to pass.
Second.
seconded by Representative Matheson. Any discussion? We're in 2199, Edna. The motion ought to pass by Representative Foley, seconded, ought not to pass. Thank you. Made by Representative Foley, seconded by Representative Matheson. And we are ready for the vote.
Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Chimino?
Yes.
Representative Chimino, yes. Representative Clucci?
Yes.
Representative Clucci, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 10 members of the committee haven't voted in the affirmative and 0 in the negative.
Right, thank you. So that'll close the work session on LD 2199. We're going to take an hour for lunch, so we'll be back at 1 o'clock. Committee Democrats, we are going to continue caucusing over lunch, so grab your lunch and join us in the chair's office. Thank you. Welcome back, everyone, to Health Coverage Insurance and Financial Services Committee. We have some snack money from who? Is that?
Representative Arford.
Okay, we'll collect that when she comes back in. We are continuing our work sessions and it sounds like we're getting a little punchy already and it's only 1:00. And we're going to open the work session on LD 2201.
Okay, so I had combined, for the purposes of your discussion today, the approach in 2190 and the approach in LD 2201. Seems to me the committee is focused on looking at the approach taken in 2201, given your earlier vote of ought not to pass on 2190. So I'm going to shift to the second page of the analysis to just outline for you some of the issues related to this bill. I think, as everyone knows, this implements one of the recommendations of the commission to evaluate the scope of regulatory review and oversight over healthcare transactions that impact the delivery of healthcare services in the state. And I did include for you just an excerpt from the commission's report that attached to the chart that sort of describes the rationale for the commission's recommendation with regard to the approaches taken in LD 2201. And LD 2201, as drafted, has sort of two components. One is a process for review and approval of certain transactions involving private equity, and then a second section that requires healthcare entities to provide notice to the state of transactions involving private equity when there's a change in majority ownership or a private equity entity takes operational control over a healthcare entity. So that notice provision and requiring some ongoing reporting to the state about ownership and control of healthcare transactions was a unanimous recommendation of the commission. The second component, which is the first component as you look at the bill, the regulatory process for review and approval of transactions that focus on private equity companies, hedge funds, or management service organizations acquiring majority interests or where they take operational control over a healthcare entity. That was a majority recommendation of the commission, and that's sort of noted in the footnote for you on the attachment. So I've sort of given you a broad overview of the components of what the bill would require. It requires both or authorizes both a preliminary review of transactions, a more comprehensive review if certain, elements or criteria are triggered. It involves post-transaction oversight over these transactions that gives some enforcement authority to the department and to the Attorney General. And then the review process itself is carried out by the Department of Human Services in consultation and with the Office of Affordable Health Care. And I think, as the committee will remember, the proposal as it's drafted is based in part on legislation that was considered last session, LD 1972, but it is more narrowly tailored in its definition and scope of what transactions would be subject to review. And LD 2201 focuses on transactions when a private equity company, hedge fund, or management service organization acquires majority and ownership interest or takes operational control of a healthcare entity. And those specific terms are defined. So, I mean, you know what a majority interest would be in terms of acquiring, but operational control is defined in the legislation as well. And so one of the things I think that the committee needs to think about as you consider whether or not to move forward with LD 2201 is the scope and how these transactions are defined and how the terms are defined, because you did have a number of concerns raised in the public hearing about the definitions and the scope. The primary one, I guess I would raise for you, is healthcare entity. The way that's defined is it does exclude nursing facilities. So it doesn't include nursing facilities and nursing homes. They were excluded from the process in the proposal in LD 1972. So that was carried forward in this proposal for drafting purposes. But you may want to consider whether or not you want to broaden the scope of the definition of what transactions are covered if you are concerned about private equity transactions or the involvement of private equity with nursing homes. You may want to address a definitional change there, I guess, I just wanted to point out for you that the definition of a healthcare entity, while it's broad, it does exclude nursing facilities. You also heard some concerns about the scope of the definition of management services organization. There have been some suggestions about clarifying that. As I mentioned, what operational control means. You may want to take a look at that, but the focus really is the transactions that are going to be subject to review, as I mentioned, are going to be those transactions where a majority interest is acquired or operational control of a healthcare entity within the state, occurring during a single transaction or in a series of transactions involves a private equity company, a hedge fund, or an MSO. And private equity company is defined. There were suggestions that perhaps that was too broadly defined for you. And as I mentioned, management service organizations was also defined, and there were also suggestions that that definition was too broad. So as you move forward, I think you'll need to pay particular attention to the scope and of the legislation and the definitions of those terms. It was also suggested that the committee needed to consider the added regulatory burden on applicants if this moves forward. For those transactions that would be subject to review. You also, I think, will need to think about the added regulatory burden on the Department of Health and Human Services for adding this as a component of something that they look at, the Office of Affordable Healthcare, whether or not there'd be, I would expect that you would see some sort of fiscal impact that involves a need for additional resources and perhaps funding. There is a provision in this legislation as drafted, which again is modeled after what was included in LD 1972, that would provide funding in part through an assessment that would be paid by health insurance carriers. You did have some concerns raised at the public hearing by representatives, health insurance carriers about that funding source. And let me see, sort of other sort of broad issues, I guess I would raise for the committee just to be aware as you're thinking about this moving forward. There is rulemaking authority granted to the department as part of this process. The draft or the bill designates those rules as routine technical. We've talked about this before. If the committee is interested in making sure or having a role in approving those rules, you could designate those rules as major substantive. That's something to consider. And then finally, there are also provisions in here about certain information being filed with the department that's during an ongoing review that would be designated as confidential, that would be provided by applicants. And I think, as you're all aware, if you do move forward with a provision like that, it is an exception from the general provisions of the Freedom of Access Act, and those provisions creating a new exception are subject to review by the Judiciary Committee. So if you move forward, it'll just add an additional sort of step and layer before the legislation moves forward. That's sort of like big picture stuff, I guess. Happy to talk more about the specifics if you want to go through sort of the specifics of what the bill itself would require in terms of the review, the steps of the review, and sort of the timeline that's laid out. It does require, particularly if a transaction is identified as one that would be subject to comprehensive review, the legislation lays out sort of specific criteria and outlines the kinds of things that the department, with the assistance of the Office of Affordable Healthcare, will be reviewing as part of the transaction. I'm happy to stop there and answer any questions.
Thank you, Colleen. Questions for Colleen? Representative Foley?
Thank you, Madam Chair. Colleen, I'm having a hard time understanding the reporting of ownership and control. I don't understand why this requires healthcare entities to report every year whether there's been a change in ownership or not. For what purpose? I mean, I don't understand why that's another necessary burden that,
Yeah, I
and
mean,
it accomplishes nothing.
well, I think part of the reason why it was included in the original legislation and why sort of the notice provision was discussed at the commission level and included in this was, I think for transparency and for, I think there's a gap in knowledge about the ownership of healthcare entities and the extent to which private equity companies and hedge funds and management service organizations might be involved in existing arrangements. And so this was, as I understood it, a way to require that information to be gathered, reported to the state, and then provided to the public for transparency. And so that's my understanding of where that came from. Just because hard to find that data. There's no affirmative requirement for that to be disclosed to the state. And so the notice requirement in the legislation kind of builds upon the existing reporting that hospitals and other entities do to MHDO with regard to sort of ongoing reporting of financial data and other data that they're reporting to MHDO, that this would be an additional component, that there would be fields required that would be reported to them about their ownership.
Representative Foley?
I mean, I understand that if it's involving a transaction that's going to occur, but to try to go backwards, again, and to do it every year, I mean, every year you could just say ditto. I mean, it's the same, but I just don't understand why we would want to put more burden unnecessarily. And I could, again, I could say, in the result of a transaction or pending transaction, this information would be necessary, but I just.
Yeah, I mean, the way it's drafted now, it's sort of on an annual basis and upon the completion of a material change transaction. So you could certainly, I think, modify it to, and I think what you described is sort of ditto. I mean, I think there'd certainly be an opportunity to provide that, to allow that if there are any updates. You just report on an annual basis, no updates or something. So you could probably, if it's not clear enough in the language, provide that as an opportunity. If you wanted people to do the annual updates, you could also certainly modify the legislation to only require reporting upon the completion of those transactions. So it certainly would be up to you.
Representative Boyer?
Thank you, Madam Chair. Colleen, do you think it's clear or needs to be, if it's not clear, can you help me with ways we could make it clear? Like in my mind that the applicant would still make an application to the department, and whether it goes through the traditional CON or whether it qualifies as the material change transaction. Do we need to add language sort of like if you fall under material change transaction in lieu of CON, or you're not also subject to the traditional CON review?
Yeah, I mean, I think my understanding was it would sort of happen part and parcel, together. But I think if there needs to be more clarification about that, you could certainly do that. I mean, I think generally the timelines and things I think are consistent with that, but we could certainly clarify that you're not, in terms of like documentation, you don't want to duplicate documentation that would be provided, or that
Yeah, it's just sort of to signify that it's not like you have to do a CON and you have to do this. Like,
it's like
yeah.
Yep. I mean, there are, as you mentioned, under existing provisions of CON, when there is a change of ownership and control,
Mhm.
you have to go through that CON, there's a process for CON. This would, I think, say for those changes of ownership or control that involve the private equity situation, they would have a deeper dive, if you will, but we can certainly make that a clarification. If it's not clear enough that it happens kind of alongside that same process,
Yeah,
that's what.
that's what I'm thinking. And Madam Chair, can I ask a follow-up?
Sure.
So then I had another question. I received some feedback on material change transaction not being clear that it was private equity companies, hedge fund, or management services organizations. Do you think that there's any additional, I mean, it seems clear to me when I read material change transaction. Do you think there's any way that that's unclear what entities are being captured here?
I think if you look at the definition, it seems clear to me because it says it's acquisition of a majority interest or operational control of a healthcare entity. And this is the definition on page 2, subsection 7, within the state occurring during a single transaction or in a series of transactions by a private equity company, hedge fund, or management service organization. So that's clear to me within the definition. If folks are concerned that it's not clear enough in the substantive language, I guess you could restate the definition, but the definition should stand on its own. In other words, that it only applies in these situations, but you could, where it says in section 372, this subsection governs notice regarding material change transactions, you could repeat private equity if you needed to. I don't think it's necessary, but you could certainly do that for, I think it might be a little belt and suspenders, but there's no reason why you couldn't.
Additional questions for Colleen? So Colleen, the definition for management services organization that was brought up by the Maine Hospital Association, the suggestion from the Maine Hospital Association, I'm certainly okay with that. The committee would consider that as well. I think that definition did need to be clarified.
So my understanding is there was some concern that the definition wasn't narrowly focused enough on a management service organization owned by a private equity company, making
Correct.
that clarification. I think that's consistent. I think Maine Hospital Association and others, I think, made that comment. So, yep.
Additional questions for Colleen? Discussion from the committee? Representative Olson?
Do we have someplace in a different statute or whatever where the responsibilities of the office or the entity is as far as safeguarding of private or proprietary information?
Sorry, I couldn't understand.
Yeah.
Is this
We have
question for
some, in
Colleen?
some other ordinance or whatever, or maybe in their organizational, whatever, their responsibilities in regard to proprietary information, safeguarding that information.
Yes, so if you look at page 5 of the bill, there are provisions in there that account for that, I believe. You may want to take a look at it and see if it is adequate, but if you look at paragraph D at the bottom of page 5, it requires the department and the Office of Affordable Healthcare to keep confidential all non-public information and documents obtained under this section and may not disclose that information to any party without the consent of the party that produced the confidential documents, except they may disclose information to their consultants who are part of the review, as long as they're bound by those same confidentiality requirements. The confidential information documents and work product are not public records and are exempt from FOA. So that does seek to designate information as confidential. I think one of the things, as I mentioned, these provisions will undergo review by the Judiciary Committee. One of the things that the committee might consider if you move forward is clarifying that further, because it just says, so keep confidential all non-public information Doesn't necessarily say what that information is, but clarifying it to say proprietary information, for instance, and there is a definition of proprietary information. That is typically used to sort of, carve out what that would be. It may be, there may be other components that they think would be confidential. Don't think that there'd be individual, like, personally identifying information, that would be like medical records or things like that, probably that would be disclosed as part of that, but those are typically what you would say, but it does seem, just referring to all non-public information doesn't really define what the scope of that is. And so if you did move forward, I might suggest, cross-referencing some existing provisions, like, trade secrets are protected as confidential, for instance, or cross-referencing something in the statute that identifies what information is confidential. I also make that recommendation based on my experience in going through these reviews with the Judiciary Committee, because they often want to see, one of the criteria that they look at is the exception as narrowly tailored as possible. And I think making specific cross-references are helpful to sort of meet that criteria when they're looking at it. So that's just my suggestion on that. There is language.
Representative Boyer.
Thank you. Thank you, Madam Chair. And I do have a question for Colleen. Colleen, on page 4 of the bill under the comprehensive review process B, could we add in to number 7 what we're trying to accomplish in 2197? Could we add like the sale and lease back in here? As a way to try and make sure we're getting a sale and lease back tied to private equity hedge funds and a tailored version of MSO.
Yeah, I mean, I think that language as drafted is trying to get at those types of arrangements, but you could certainly sort of add language, including, transactions where there's a sale and leaseback of a main campus or something, to be more specific about including that in as a criteria.
And then-
Absolutely. Yep.
And then similar with like what we're trying to get at in 2198, could we also add in here maybe an additional line of ratio of debt?
Of
to
the debt
equity
ratio, absolutely.
For
Yep.
them to
Yep.
review.
Yep, you could certainly build that in, and make that a little more explicit. I mean, there is a broad sort of catch-all category, any other factors that the office determines to be in the public interest, but the more specificity, I guess, is that you want to include. And I think you could certainly build in those as an alternative to sort of adopting a prohibition on those practices, have them be looked at as part of the review process.
Great, thank you.
Representative Foley.
Thank you, Madam Chair. On that healthcare entity, I mean, that's a pretty broad definition. I mean, a healthcare entity means a healthcare provider, a healthcare facility, or a provider organization. I mean, that could be a dentist.
Yeah, and the definitions and each of those
And that's
terms
not
is,
what that's not
is-
what we're after.
and each of those terms are further defined as well. So, healthcare providers defined, healthcare facilities defined, and healthcare, services are defined. So, yes, so, my suggestion about, I think it's important, pay particular attention to the definitions and scope is going to be important for your understanding of like what transactions are going to be involved. I think you have had some testimony and the commission had some testimony that there is some private equity involvement in the dental, in dental care. Of course, you've also had, testimony about private equity involvement in nursing care, nursing facilities. That's carved out here, but if there are other areas that you wanted to carve out, you could certainly carve them out or carve them in, but paying attention to, put them in or put them out, but paying attention to the definitions, I think is going to be important. Yeah.
I mean,
Right.
no, I lost my train of thought. I'll come back to it.
But I would say, right now, the definition of healthcare services includes dental, so. If you look there, so I think they would be included.
Senator Bailey.
Thank you, Madam Chair. So along those lines, as far as exceptions on page 10, under number 3, it's certainly, it's currently 5 or fewer physicians, which I wonder if that should be providers and not physicians.
yeah.
Yeah,
Small entities, yes.
yes. But also if that was a number that came up at the commission where the number 5 came up.
That was carried forward from LD 1972. I don't think
Okay.
the commission had any specific discussion of a number.
And
But
so when we were,
exempting out
when we
small
were
practices.
talking about maybe what the number should be, we were trying to remember what number we used for the Bureau of Insurance small provider complaint process.
Oh, yeah. I think it
Do
was.
you remember?
It might have been 5, but I can look it up. It might have been 3. Let me look.
Wow, okay,
I'll look. I'll confirm that right now.
okay,
Yeah.
thank you.
Yeah.
Just thinking that maybe we want to be consistent or not.
Yeah,
Um,
different.
but-
Yeah, you could.
I thought it was 6, so.
Oh, maybe it was.
I thought it was 10.
And
See,
Representative House-
let's see who's gonna be right.
Exactly. Do I hear 4 by anybody? Do I hear 8? What did- Yeah,
I think that's fair.
that's what we concluded was Colleen will know.
That's 6.
No,
There you go. You get the prize.
Such a brat.
6 or fewer. 6 or fewer.
I have no idea where that number
Yeah.
came from, but
I
that's
don't
what I had
either.
remembered,
I
yeah.
don't know, 5 is probably a rounder number. I don't know.
Okay.
6 is that.
So that's out there,
6 is
if we want to change that number or not.
And you
and
can
it may-
certainly,
Yeah,
Oh,
you could go
no.
to 6, you can go to 10, whatever. Yeah, so
and you
just
had
for
suggested
discussion.
Thank you.
not being so focused on physician, but other
Healthcare
other-
providers.
yes, exactly. Thank you.
More discussion from the committee? Representative Foley.
Yeah, I'd just like to go back to the reporting. I'm wondering if we could say a healthcare entity shall report to the organization initially and then only upon completion of material. I just don't want to see it. I mean, yeah, we could do it one time, but then only if you're gonna do it. Does that make sense to?
Yeah, that makes sense.
So maybe once, and then if there's any additional transactions or changes.
Some sort of a
Yeah,
trigger.
yeah,
Yeah.
or any
Mhm.
updates. Yeah. And so I just wanted to clarify, when we're talking about exceptions, we're talking about exceptions from the reporting, not from the review, because that's where that exceptions applies. So you weren't talking about accepting small practices who are purchased by private equity from the comprehensive review or not, were you?
Well, we can talk about that.
Okay, because I just wanted to make sure
But
that the
yes, I
exception
was-
only goes to the reporting. So that's all I just wanted.
But yes, I was specifically referring to that,
Perfect.
but certainly we could talk about whether in our definition of a material change transaction, if we should exempt small providers and be consistent in our definition. I'm open to discussion of that.
Yeah, I mean, there are, just to point out for you, there are not exceptions necessarily, but there are, when you talk about what is subject to preliminary review and what is subject to comprehensive review, there are sort of some triggers. So comprehensive review would sort of be automatically triggered if a transaction had a certain amount of, assets involved, right? So, and so that would be automatically have to happen, but there are some triggers, so you might want to think about it where, you don't have a comprehensive review for certain transactions, but maybe they're in the preliminary review category or something, as opposed to an outright exception, but you can also approach it that way as well. Just throw that out there. The level of review.
Additional discussion from committee members? What is the will of the committee? Everybody's looking down. A lot to digest. In terms of the changes that we're talking
No,
about, or
it's
just the
just-
whole bill? Yeah.
Pretty weighty, plus I wasn't there.
Yes, yes, you're.
Don't make me spit my water again.
Representative Boyer.
Thank you, Madam Chair. I guess, can I just ask a question of the committee on my suggestion that we potentially add the ratio of debt to equity and lease back in into this bill, like how the committee is feeling about that?
I'm personally okay with that, but yes, Representative Arford.
I absolutely think it makes good sense and thank you for suggesting that.
Representative Olson.
If you were to do that, it opens up a whole definition section that has to be changed and some things like that. If you start to bring in the debt to equity calculus into this bill, where it was, when we were looking at it in the other, we knew that there were some problems there too. So there's, bringing in here is not I don't see that as problematic. What I do see as problematic is we've got to then really boil down into some of the definition sections and get some of that stuff squared around too. So it's not a minor rewrite, it's a major rewrite.
Senator Bailey.
Thank you, Madam Chair. First, a question. While I was out, did the committee talk about rulemaking and whether they're going to keep it routine technical or major substantive? Did
We have
not.
not talked
Okay.
about that yet.
And the reason I ask that is because it seems to me that that's where some of these definitions, like if you're talking about debt to equity ratio, I think they could do that in rulemaking. And certainly if the committee wants to review those rules, we make a major substantive and do it that way would be my suggestion. So I'm okay with putting those in answer to your question, Representative Boyer, but I would like to see any rulemaking be major substantive so that we can see what they do and see what definitions they come up with and what they're going to be looking at as part of this process.
Representative Foley.
Yeah, and the one concern or question I had, and I spoke with Senator Bailey, is defining what debt is. I mean, that's one thing if it's an equity company coming in, but let's say you have a small hospital and they want to borrow $1 million to buy an MRI machine, but their value is only 1.9. They could the bank will still loan them the money, but the debt to equity, if you don't, so do we really want to include bank loans and that? So I don't know, I struggle with what is the debt that we're concerned about? And what is the debt ratio?
So do you feel comfortable with that being part of the rulemaking, that those definitions coming back as major substantive rules for the committee to?
I mean, I certainly think the rule should be major substantive. I think that's, I mean, I suppose we could leave it for that. I just struggle with not having a clearer idea of what the debt it is that we're talking about. So I guess I'm gonna chew on that for a little bit.
Oh, yes.
Just,
Colleen
oh,
has
I
a
don't want to
helper
interrupt.
select.
Well, just on that point, we haven't talked about 2198 yet, I think it's 2198 or 2197, the debt to equity ratio bill. The way that was drafted and proposed to the committee, it would apply to any person, which I think is getting at your concern, like even debt that they might take on from a bank or another type of lender. One of the suggestions that the committee had at the public hearing, and one of the things that you could incorporate into this criteria is a look specifically at debt to equity ratio involving the private equity company, the hedge fund, the MSO. So you carve out any real like deep dive into the other types of debt that they'd be taking on, but you'd only be looking at their debt to equity ratio in terms of the debt that involves the private equity, which may help. you still could have the rules, but even clarifying that might be more in line with what you've been talking about.
Yeah, I think that certainly gets to what my really concern is. I think that really where the commission was coming from when we discussed this. So thank you.
Representative Flynn?
Thank you, Madam Chair. My understanding is the ratio is that it's the leverage ratio of the buyout, not necessarily for future equipment purchases and things of that sort. So to me, it's a clarification of it's an equity ratio on the leverage.
Additional discussion? What is the will of the committee? Yeah, absolutely.
Under the definition of management services organization, were we going to look at a better definition for that?
I think
I
they're
think
gonna look
we
at
agreed.
Jeff
I think you
also.
agreed to
Yeah.
clarify that already.
Yeah.
Okay.
That might be one of the things you agreed to as a whole, but yeah,
That
I think
was-
the idea was to clarify that it only speaks to MSOs that are owned by private equity or hedge funds or which was suggested.
That was suggested.
I'll make a motion ought to pass as amended
I'll second.
with all the amendments.
Oh, that's clear.
Wow. Wow.
Could you ask Colleen?
Colleen, do you
Someone
mind
second?
summarizing?
I did.
Yes.
Oh, okay.
Representative Boyer did.
Well, I can kind of go through where I think we are, and
That'd be
I
great.
certainly enough for
Really
me to bring
appreciate
something
that.
back to you, but anyway. So I think the amendments that you've talked about, if we're looking at the bill, I'll kind of go through the bill, right? We're gonna modify the definition of management service organizations, make it clear. What else did I have in my notes? Guess that's all. We're gonna, I'll potentially look at trying to clarify the references to confidential information, maybe being a little more specific about proprietary information and that, you know, legitimate financial information that should be confidential.
Cross-referencing. to trade
Cross-referencing,
secrets.
yeah. And on page, as part of the comprehensive review process, we're going to modify the criteria that they look at to build in the issues raised in 2197 and 2198, so that the review would look at the impact of real estate sales or lease agreements on the financial condition of the healthcare entity, including, you know, the sale and leaseback agreements for the main campus. We're going to add criteria that would look at the debt to ratio involving private equity, limited to the private equity MSO. The debt to equity ratio between the healthcare entity and those private equity types. We are going to make the rules major substantive. We are going to modify the reporting requirement to be a one-time report, and then any updates upon completion of a material trade change transaction. And I believe we are going to modify the exceptions provision to bump that up from 5 to 6 and clarify that it's independent
Providers.
provider organizations applies to all providers, not just physicians. Did I get it all?
Representative Boyer?
Thank you. And then
Is it-
just if we needed to add language to sort of clarify that it's complementary to con.
Oh,
not a
right,
separate-
yes, I forgot that one, yes.
To CON, sorry.
Yes, yes,
CON.
thank you.
Discussion? Seeing none? Time to take a vote?
Thank you. Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Alford. Representative Alford, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Shimino.
Yes.
Representative Shimino, yes. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Olson.
Yes.
Representative Morris. Sorry.
It's all right, yes.
Representative Morris, yes. 10 members of the committee having voted in the affirmative and 0 in the negative.
Okay. Sorry to derail you, but I have one more question.
Sure.
Because oh, I think it's right. The effective date of this is 1/1/27, which I think is fine, except talked about major substantive rulemaking. So I may, after I think about it, may include some sort of unallocated section, you know, in terms of the timeline for the major substantive rules. So
Okay.
that's all. Just to
Great,
Heads
thank
up.
you. Sorry, I just have to write that down. I'll forget it.
You can keep going.
All right, so we're gonna,
197.
yeah, we're gonna do 2197, and since we incorporated that, I don't think we need to work through the bill analysis. Do I have a, oh boy, do I have a motion over there?
I will move, ought not to pass on LD 2197.
Do I have a second?
Second.
Great. Any discussion? So we have a motion on the floor ought not to pass for LD 2197.
Representative Mastracchio made the motion and Representative Foley seconded.
And we are ready for the vote.
Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Arfoot.
Yeah.
Representative Arfoot, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Shimino.
Yes.
Representative Shimino, yes. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Morris.
Yeah.
Representative Morris, yes. Representative Olson.
Yes.
Representative Olson, yes. 10 members of the committee having voted in the affirmative and 0 in the negative.
Great. And then we can move right on to LD 2198. And do I have a motion? Representative Mastracchio.
Thank you, Madam Chair. I will move ought not to pass on LD 2198.
We have a motion ought not to pass on 2198. Representative Mastracchio and seconded by Representative Foley. Any discussion? Seeing none, we're ready for the vote.
Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Arfoot.
Yeah.
Representative Arfoot, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Shimino.
Yes.
Representative Shimino, yes. Representative Flynn. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Morris.
Yeah.
Representative Morris, yes. Representative Olson.
Yes.
Representative Olson, yes. 9 members of the committee having voted in the affirmative and 0 in the negative.
Great, thank you. Great.
Thank you.
All right, now we're gonna open the work session at LD 2189. I think we need you to go through the analysis, please.
So do whatever you
Sorry.
like. No, that's okay. I don't wanna
Yeah, you
stop
never
the
know.
train if the
Yeah.
train's on the
No, no,
tracks.
No.
Okay.
We're going back to working.
LD 2189. This is another proposal that seeks to implement a recommendation from the commission. This was one of the unanimous recommendations. As it's drafted, it requires a hospital to provide at least 120 days notice prior to the termination of maternity or newborn care services, or of a change in the level of care a hospital provides for maternity and newborn services. The bill seeks to codify the guidance that was developed by the Department of Health and Human Services that was not mandatory. And LD 2189 seeks to codify the guidance and make it mandatory. A copy of the guidance is included for you on pages 5 and 6 of the analysis. One of the things, I guess, and some of the issues that were raised during the public hearing was whether or not the bill should be amended to go further beyond a notice requirement. You did have testimony suggesting that the bill be amended to authorize DHHS to review and approve closures of maternity units, and to require also to expand the scope to include both notice and review of closures of any healthcare service by a hospital. It was also suggested that additional notice be required that perhaps wouldn't be shared publicly, but allow some more advance notice to the department, and others to allow time for planning with all necessary parties to ensure coordination and continuity of care for those in need of maternity care in a hospital service area. And also that, the committee should think of other approaches, policy approaches to address the underlying need to preserve access to maternity care in rural areas. The commission did talk about potentially whether or not to go beyond a notice requirement, but my understanding and recollection was really this was where the commission could agree on a kind of a unanimous recommendation. With regard to this, they talked about potentially broadening it to include all types of services and notices. And so this is where they sort of landed, I guess I would say. Representative Boyer and Representative Foley can weigh in on that. But I think they viewed the proposal as sort of a first step in with regard to the notice requirement. You did have some testimony also that you might want to consider suggesting an amendment to allow a hospital to provide less than 120 days notice when circumstances require. Potentially adding language that in cases when notice, 120 days prior notice cannot be done, the hospital should provide notice as soon as practicable. You could specify that further. I think it was suggested sort of in the back and forth to the committee, perhaps 5 business days or fewer, but you could consider that. Sort of one technical suggestion that the Department of Health and Human Services made in their testimony is that if the committee does move forward, they would suggest sort of allocating the language to a different section of statute in Title 22. As it's drafted now, it's placed within the CON chapter, and they suggested just moving it to a different chapter that has some corresponding provisions in it that relate to notices and closure of services. So if you do move forward, we just put it in a different section, which makes sense. We don't yet have any fiscal information with regard to this. I would also note that in response to the committee's questions on this bill for more information, you do have some follow-up information that's come in by email. And I think Edna printed out hard copies for you from Northern Light Health and Maine Health in response to requests for additional information. I'll stop there.
Okay. Questions for Colleen, Representative Olson.
Thank you, Madam Chair. I guess what I'm wondering here is, so we've got this, we say they have to, they have to give this notice. What happens if they do not? There's no, there's a carrot, but there's no stick. So if they don't give notice, then what are they gonna do? Say you can't shut down, but you have no people, so.
Yeah, I mean, there's no specific penalty here, but, the department would have general authority to take action for violations. So if there was a violation of the notice requirement, the department could potentially take an action. I don't think there's any sanction in here in terms of if the notice doesn't happen. There's no language in here that says they can't close, like you said. It's just, I think a response to, they have this voluntary guidance that's out there now. The testimony that the commission received was that some hospitals were complying with that and others were not. This would make it mandatory and would provide some additional advance notice to the department to allow some coordination, but also would provide that advance notice to the public, which you had another piece of legislation last session, trying to address the difficulties that communities have had when not getting the prior, enough notice or prior notice of these closures.
Further questions? Representative Foley.
Yeah, I struggle with this one. although I supported it in the commission, I still have been struggling with. I mean, these are difficult decisions that have to be made by hospitals. Let's say we got 120 days. And so the hospital announces 120 days, we're going to be closing our OBGYN and delivery services. And the entire staff quits the next day. Now that they've had 1 day notice. I mean, that's, that's the reality of what will happen. And I guess when I look at notice to the public, to me, the only people that really need to know are the people who are going to be impacted. That would be the person, the woman who's 6 months pregnant, potentially having the baby delivered, and the hospital's going to close in 2 months or whatever. That's the person that really needs to know. If the general public, I mean, why do they need to know? Although they will find out because of social media, but to me, if I'm looking at this, I'm saying we really should be protecting the people that need to know. That's the person that really needs to know, because they're the ones that have to go find another service or do something else. I wouldn't, it did. I mean, especially when we're talking about this one particular service, because this impacts just a certain group of people, and very important group of people, but just one group of people. So I know I struggle with that. I would almost like to say that notice to the patient impacted or something. I don't know. I just have a hard time with that.
Representative Strachey.
Thank you, Madam Chair. It isn't just the person though who's pregnant, who thinks they're going to have a baby there and then isn't going to be able to have their baby there. It's people who live in the area that think that's the hospital they're going to go to. And I can tell you, having experienced closures in my town, they are still talking about it, and it's over 10 years. Longer than that for the OBGYN. You would think and we've got Southern Maine, we've got York Hospital. I mean, we had all kinds of choices still, and yet that was like the worst thing that could happen. So I don't think it really matters. I'm more concerned with it not seeming like it's something sneaky that happened, because that's how people perceive it. You didn't tell us. We didn't know it was going to close, and then you wake up the next day and it's closed. And you're right. It might not affect me because I'm not having kids now, but clearly it affected a whole lot of people because I still hear about it. And they weren't having babies. So I think it's just part of that continuum. If you have a child so I have a daughter who's having a baby and she has to go really far away. Well, that impacts me too, because maybe I have to take care of other kids or now more women are going to be having sections because they want to plan it, or induce births, and those create all those other health issues. So yeah, there's a whole lot that's tied into this that is not just simply about closing a unit. I mean, I think that are all related to healthcare. So yeah, I struggle with it too. How do you notify them without making it come faster and quicker? And yet, are we going to subsidize those units? Because what I'm thinking is the only way is an infusion of money. And then you still have the issue of people who aren't doing enough births to have enough experience, the kind of experience that they say you need to have all kinds of births be happening in that kind of a birthing unit. So, I mean, I just think that this is, pardon me, but it's kind of simplistic and it's like lulling us into thinking we're doing something, but I don't really feel like it really does anything. Sorry, but do you understand? I mean, it's not I think it's too big to think that a couple of sentences here is going to do anything.
So Colleen, I had a question about the suggestion by ACOG in their testimony about kind of setting up this two-tiered system. My question though is there anything that currently prohibits a hospital from doing what they suggest and confidentially notifying the department and setting up a planning meeting or anything like that?
It wouldn't prohibit that. It would, It wouldn't prohibit that because it says shall file at least 120 days prior.
Yeah,
I
but I'm
think if
just
there was
asking
a-
currently, is there anything that
No, I don't-
prohibits them from
No,
doing that?
I don't believe so. No, because right now they have the voluntary guidance and they do share it. I mean, I guess the one thing I would say is that there's a concern that if they provide notice to the department that that could somehow become public sooner, there might be a need for some language protecting that information from being disclosed if someone asks for it pursuant to, pursuant to a FOA request or something, if there'd be some concern. So, I don't think there would be anything to prohibit that, but you could put something in there like if a hospital, information can't become public until that 120-day time. Perhaps you could put something in there like that. That's what, if
Yeah, I
there'd be
mean,
a concern.
I do want to
But even this wouldn't
encourage
prohibit it.
hospitals
Yeah.
to, reach out to the department and have these planning sessions. So I'm just struggling
Yeah.
how to do that.
And I mean, I think the concern, I don't want to speak for the hospitals, might be that if they do it too early, it might somehow become public. So some sort of protection would
Right.
be helpful. And the language here wouldn't necessarily have that protection. I haven't looked carefully at the rest of the provisions in the Title 22 to know if there'd be some adequate protections in other sections of statute. I know DHHS is here, hopefully. Maybe they could, if there's something that would protect those conversations. Or documentate, if documentation was shared about that ahead of time from becoming public or the potential for it to become public.
Okay, if someone from the department can maybe help me with that.
Hello, Bill Monteo, the Director of Licensing.
Okay.
What you're describing, Senator Bailey, actually currently does happen with some hospitals. We've had a critical access hospital reach out to us, I believe it was 5 months early, looking for assistance because they were trying to brainstorm with ways that they could keep providing the service and not closing it.
And that's what I want to encourage.
Yes, and in the guidance that we produced, hospitals notify the Division of Licensing. We immediately notify the CDC's Maternal and Child Health Officer, Marianne Harkle, and the department's Chief Child Health Officer, Dr. Amy Belial. And then after the notice that we provide, licensing takes a step back because we're regulatory. And those entities get involved in discussions with the hospital and kind of look at root cause analysis of what led to this and is there any way that the department can help and assist with keeping the services open? So that currently does exist and it does happen. It doesn't happen with every hospital.
When that happens, I mean, what was suggested by ACOG that there be, the notification should activate a collaborative review process, which it sounds like you did do that, involving hospital leadership, obstetrics, emergency medicine, EMS, risk management, and the state's perinatal outreach team. So when this process is used, are you able to incorporate outside entities that may be impacted, like EMS, for example, and still have that information remain confidential? Or at what point does it become public?
So the way the current process works is Marianne Harkle and Dr. Belial do the outreach with the hospital, and then the hospital invites or brings in entities that they feel are appropriate. It doesn't get to notification of EMS or outside services until we're looking at closure is imminent and it meets that. In this case, it would be the 120 days to allow for that notification. If you're looking for, can it happen? I think it could. The question is, at what point, what would we need? And I would have to meet with our AEG to see if there's provisions that we would need to keep those conversations confidential. Currently, they happen outside of my office. They happen with other parties within the department and with the hospital itself.
Do you have any suggestions to, again, encourage hospitals to do this process and try to collaborate and try to brainstorm is what it sounds like to me, right? To see if the unit or hospital can stay open. Do you have any suggestions on how we can encourage that?
Yeah, the only one that I would have off the top of my head, Senator, is that we could put out what we refer to as a letter of guidance that encourages hospitals to do what you're describing. The provision of what this bill would accomplish would be to essentially establish a mandate that no less than 120
Right.
days we would get notice, but we can certainly put out a letter of guidance to hospitals encouraging that. Beyond that, I don't know that we could do anything on a more of a regulatory process, because then it becomes less encouragement and more of a statutory or regulatory requirement.
Right. Yeah.
It could certainly be something we could, when we do amend the hospital rules, put in a provision related to the rules for hospitals to provide notice as well.
Repeat that.
We have licensing rules. All hospitals are licensed. So when we revise the rules for hospital licensure, which many of our rules are woefully outdated and are in queue, we could at that point revise the rule to address and encourage notification at a prior date, earlier than 120 days. I don't know that we could keep those conversations confidential just based on rule. We'd have to discuss that with our AEG.
Representative Boyer.
Thank you, Madam Chair. Thank you, Bill. Could you, I think it was asked earlier, but with this voluntary guidance, if we codify it as we're with this bill, what would you anticipate if a hospital didn't follow the 120 days?
But currently,
the
there's no
department
ability
do?
to fine or sanction hospitals. So the enforcement piece of this would be a conditional license. So the department does have the authority to issue a conditional license with a condition. For example, if they fail to provide notice, we could issue a condition related to the notice, and we could issue a condition requiring that the hospital establish a process to ensure that OB services are appropriately addressed for the patients for an additional time frame to allow for that notice. That's a provision that we could do. It would require a lot more dialogue and look at, because as many people have alluded to, you can't, if there's no OB service, no OB physician to provide the service, you're really imposing a requirement that hospitals expend more money for a locums or a traveler or some type of coverage. As many people during the hearings had testified, these are not rash decisions. Hospitals usually are, it's either the physicians are giving notice or they're seeing a low birth rate. They are planning for this and trying to, in many cases, trying to prevent it. And all we're asking for when we do the kind of the letter of guidance process is engage us earlier rather than later. We have had a few situations where we've received 30 days notice, and we've requested that the hospital can consider expanding that notice. Even though physician services were available, the hospital said no. And there's no requirement that they do that.
Thank you. Any other questions for Mr. Montejo while he's up there? Seeing none, thank you.
Yep.
Representative Matson.
I guess I just asked the committee, what and why would we be concerned about codifying an already established process that should be followed for an advisory? Where's the concern there with the committee?
My understanding is because it's voluntary, so putting it in statute.
No, what
Okay.
I'm asking is, why is that a problem to put it in statute for the committee to consider? I don't have a problem putting an advisory into statutes. I don't have a problem with this bill. I'm just asking the committee what their concerns are about putting.
Representative Mastracchio.
It's not that I have a problem with putting it into statute. It's that what's going to happen? How are things going to change? Is that birthing unit going to stay open? I'm just asking. So you tell me the point. We can say it, we can ask for notice, but what happens and changes for the patient? Just that, and I'll be honest, if they if I was one of those pregnant women, I got a confidential information that it was going to close, it wouldn't stay out confidential very long because I'd be telling people. I mean, I would. The public is going to tell when they hear something like that. I mean, social media, I mean, just your friends. So I guess I'm asking, what's the point? And if you can convince me that it's something, I mean, we've spent a lot of time on this, and basically what we're just talking about is codifying something that's already in practice, but only voluntary. Right? It's nothing else.
I mean, I
So
guess I
what's the
thought of
point?
it as, I thought of it as, what I heard from people around my district is that there wasn't enough time to plan. So this gives more time to plan. I agree with you that it doesn't solve the problem of the closures necessarily, but I do think that it does help, it helps people understand what's happening at least. And I think there's a value to transparency on that part for patients. Planning.
Representative Chimino.
My concern, though, is that once the announcement is made, that they're gonna lose doctors. Doctors will already be looking. So again, you may end up going, it's not a 120-day notice. It may be like a week notice. And then the patient is in a worse situation. I don't support this bill. To me, there's no enforcement. I don't think it gives hospitals enough time. I worry about the loss of people once this is announced. I think it's reactionary. I mean, I think we're trying to do is make it look like we're on top of it because perception is reality for folks. And we want to make it look like that we're actually doing something, but I don't really think this accomplishes that. So I'm going to be not to pass.
Representative Boyer.
Thank you, Madam Chair. I would just say that the hospitals agreed to this timeframe, and there was on the commission not a lot of agreement. This was a unanimous out of the commission. We had 2 hospital representatives on the commission that agreed, and there was a lot of talk about 120 days versus 180 days. The hospitals really felt like 180 was too long, that they would lose staff. And certainly not speaking for anyone, and Colleen can correct me, but I believe this was unanimous and the hospitals agreed to the 120 days and felt comfortable with it. I would also add, it is a small step. I don't think it's going to stop labor and delivery from closing, but I do remember hearing from the department that it would also help the department because it was voluntary guidance. Some hospitals were following it, but not all. And so if we were to codify it, put it into statute, it could potentially help the department in their work as well.
Representative Olson.
Thank you, Madam Chair. I guess my question to that would be, have anyone queried the hospitals again now in light of the supplemental budget, which could really financially impact them if this tax goes through, that all of a sudden now they've got to put out money in tax versus keeping money in-house to work on keeping these units open.
Well, we
And
did
so,
have, we
so
did,
all of a sudden that 120 days may no longer be a reasonable number.
we,
I mean, I haven't heard that from the hospitals.
Yeah.
But I mean, I haven't asked them directly, but I did speak with Mr. Austin yesterday or the day before. And no one has brought that to my attention.
I mean, we did get testimony from the hospitals. Further discussion. Oh, Representative Mastracchio.
Thank you, Madam Chair. I'm going to support the bill. All right. I'm just saying I want to be realistic because I think that what we should be looking at, this is fine. Notice is great. But I would rather be looking at ways that we can help them maintain these birthing units because without them, well, we talked about, pharmacy deserts. This is, baby deserts, maternity deserts. You can't get the care you need. Then families aren't going to go in those, they're not going to live in those areas. And that creates a whole host of other problems. So in the future, I'm hoping that bills come forth that actually try. I mean, it's not going to be cheap. We're going to have to pay for it, just like everything else. But if it's that important, then we will.
Representative Flynn.
Thank you, Madam Chair. Just recalling Dr. McCulloch had made comments. And the reason for the lukewarm support is that it does not address the underlying causes of the problem to prevent it from happening. It acknowledges the problem of unit closures, but says it can just happen more slowly. So I think we are to a degree being reactionary, but to Representative Boyer's point, we're doing something here. So although it might not be ideal, I would support it at the position it's in.
Representative Arkford.
Yeah, thank you, Madam Chair. I also, have been considering Dr. McCullough's testimony, and I think what she states is obvious. This bill does not fix the problem. It simply fixes the lack of communication that people testified was currently happening that allowed them anywhere near adequate time to prepare and plan for a hospital closing their OBGYN unit. So, or the ability to deliver babies. So I will support it for that reason alone, but I also say that, there's another session around the corner and that we now know that this does not fix a problem that needs addressing. So I'll leave it at that, but I think we're all been made well aware of that.
So I'm an odd to pass with a letter. I know, you're all shocked.
Say ought to pass with the letter?
Yes, ought to pass with a letter, and the letter would be to the department to, and you know what I'm gonna say. Yeah, to do the letter of guidance and to look at their licensing rules. And as part of that, to explore the extent that those collaboration agreements, meetings, can be confidential if that, helps them to occur sooner. I really, again, want to do whatever we can to encourage hospitals to reach out to the department earlier, collaborate, and try to come up with solutions as they're looking at closing units. So. Is there, sure, I'll make a motion not to pass with a letter.
Second.
Seconded by Representative Matheson. Further discussion. All right, I think we're ready, Edna.
Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Arfoot?
Yeah.
Representative Arfoot, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Shamino?
No.
Representative Shamino, no. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 9 members of the committee have voted in the affirmative and 1 in the negative. And your vote is,
Representative Shamino, you just ought not to pass. Okay. Right. Thank you. I'll close the work session on LD 2189. We'll open the work session on LD 2200. I think go through and then obviously explain my proposed amendment, please.
Sure. So LD 2200 is another bill that proposes to implement one of the recommendations from the commission. It prohibits non-compete agreements for healthcare practitioners. This was not a unanimous recommendation, but it was a majority recommendation of the commission members. Under current law, which I attached for you, you'll see the current law starting on page 5. Non-compete agreements are enforceable only to the extent that they are reasonable and are no broader than necessary to protect the following legitimate business interests of an employer. It specifies trade secrets, confidential information, or an employer's goodwill. There's also language stating that a non-compete agreement may be presumed necessary if legitimate business interests cannot be adequately protected through an alternative restrictive covenant, including but not limited to a non-solicitation agreement or a non-disclosure or confidentiality agreement. Current law also prohibits a non-compete agreement in certain situations. If an employee, is earning wages at or below 400% of the federal poverty level, or the employee is a veterinarian employed in a facility in which the employee does not have an ownership interest. The law defines a non-compete agreement as a contract or contract provision that prohibits an employee or prospective employee from working in the same or a similar profession or in a specified geographic area for a certain period of time following termination of employment. As Senator Bailey just mentioned, after the public hearing, she developed a draft amendment for the committee's consideration. That's attached for you on page 7. It was distributed to the committee members and to interested parties prior to today's work session. In place of the prohibition in the bill on non-compete agreements, the amendment would add language requiring that in the existing law would add language requiring that any non-compete agreement between an employer and a healthcare practitioner that is enforceable must recognize an individual's right to choose their own healthcare practitioner. So there's already a recognition, I think, in the definition of a non-compete agreement, what can be included in terms of, a restriction on, a time for practice, not to practice for a specific period of time or not to practice in a specific area. But this would build in some language specifically that the agreement must reinforce or recognize an individual's right to choose their own healthcare practitioner. I did also attach for you, it was referenced at the public hearing, a 1995 case from the law court that was a challenge to a non-compete agreement between an optometrist and their employer. So that's attached for you. Also attached for you, which was referenced at the public hearing by the testimony from the Maine Medical Association. There's a current provision in the AMA Code of Medical Ethics with regard to restrictive covenants, so that's there. And if you look at if you read the law court opinion, if you also look at some of the provisions in the current law, which was enacted, 20 or so years after the 1995 law court opinion, a lot of the elements that the law court discussed in terms of that, assisted in their fact finding, I guess, to find that this particular non-compete agreement was enforceable are sort of incorporated into the current law. If you look at it in terms of both the definition of what a non-compete agreement is and the elements of sort of limiting the enforceability of non-compete agreements if they focus on those 3 areas that I mentioned: trade secrets, confidential information, and an employer's goodwill. So I'll stop there. We don't yet have any fiscal information, but I'm happy to answer anybody's questions.
Okay, questions for Colleen? Discussion. Is anyone still awake? Representative Matheson.
I am inclined to support the amendment. I think that covers some of my concerns about an outright ban being in place in Maine. So I am inclined to make a motion on ought to pass as amended.
I will second that. Discussion. Representative Chimino, did you have a question? Oh, you were, okay. Representative Boyer. Discussion.
Thank you, Madam Chair. I think just my concern is that, like, I understand on Bailey's amendment, I understand it. But just, the individual would have to, if the non-compete does not follow this guidance, the individual would have to bring a suit. And I think that's just
Either party.
my concern.
Yes,
Yeah.
that is true. Further discussion. I guess we're ready to vote, Edna. Okay, go ahead.
Hold on, hold on. All right, Colleen, under current law, non-competes are enforceable only to the extent that they're reasonable and no broader than necessary. So can you help me, like, is that? I mean, I guess that's probably not defined because you would have given us a definition, but has this been like tried in court already? Like what
Well, I mean,
is
the one sort of
the one that
case
was
that
brought
you
up?
can point to is this one, particular to this industry, I guess, is the 1995 case. And I think if you read the case and if you look at sort of the statute and the way it's laid out, I think it contemplates that the determination of whether something's enforceable or whether it's reasonable is going to be based on the facts, you know, of that particular case. And so if there is a disagreement with the party, or if they feel like they, you know, one party or the other is trying to challenge it, it would be something that a court would look at. They would look at all the facts, they would look at the statute. They would look at any prior case law, and, you know, there is that the analysis that the 1995 law court went through, but it really would be sort of a combination of looking at the facts and an application of the law. And I guess I would say, you know, reasonable is a common term that is used in the statute, you
It's
know.
Representative Olson's favorite.
Right, I know, but it is commonly used, and it's something, you know, courts are familiar with in terms of, you know, interpreting, and they would look to all those things to make a decision in this particular case. But it would be done on a case by case basis, as opposed to, you know, an outright ban like the bill proposed would, you know, take care of it. It'd just say, no, you couldn't do it. But this would say you can do it in some circumstances, but you have to meet these standards.
Representative Arford.
Yeah, I'm not a fan of non-compete agreements based on experience I've had in my community and that some of my constituents have had. And so I do have a question about the amendment. The part where it says non-solicitation, it's in there. I'm not sure exactly what the extent, what that would cover. If a patient learned, you know, someone left the practice, a few patients, or maybe a lot of patients learned of where they had gone and decided to go and continue treatment with them at their new location. Would that, although the provider hadn't actually solicited them, the relationship that they'd established at the place that they were leaving is what precipitated the patients coming to them. How would that, I mean, is that non-solicitation? Is that limited strictly to the provider who's left, reaching out to past patients and telling them, yes, I want to come with you? So in other words, if the patients ended up going with them of their own volition, they would be protected somehow, like that the provider
Yes.
that was left.
And that's the language that was added, is to make.
I
that
know,
clear.
but
Yes.
is there some language we could add that would say no sort of action could be taken against the provider? I mean, I can see some sort of action where action would be taken. It's like a he said, she said at that point. I mean, did they meet up at a coffee shop and the doctor who was left says to the patient that they left behind, gee, I'd love to have you come make an appointment with me or whatever. Is that, you know, would that be
And
considered?
I don't think there's anything we can put in statute that's going to be able to contemplate every scenario
Yeah,
like that. Yeah.
I'm just not at all comfortable with, at this point in time, and I made a comment earlier that we hear very frequently that one of the problems with healthcare in general is that there's not enough competition. And here we are actually taking action to limit competition. And even though there may be very good reasons from some folks' perspectives, I'm not at all convinced of it, although I do appreciate this amendment and the changes that it makes. And thank you for that.
Okay. Further discussion. I don't know who raised their hand first. Okay. Representative Mastracchio.
Bob, I see that. You're nodding your head that I would lie. It's okay, Bob. I'm not offended. I'm actually a pretty good liar, so. Used to lie to my kids a lot about things. Anyway, but they know that now, so it's okay. I have a question for you, and because the motion on the floor, and there was a second, right, for your amendment. If I wasn't to vote for that one and I wanted to vote for the bill, is there anything I need to do to that bill to just do exactly what it was, which was say no more non-compete for?
Yeah, I think the bill as drafted is okay
Thank
as
you.
drafted to accomplish that intent. So if you wanted to vote no on the motion, it would just be a
I-
straight on to pass, yeah.
Thank you very much.
Representative Wilson.
Thank you. I mean, you know, the whole, I think the whole non-solicitation thing is fine as it is. I mean, as we discussed in some of the other bills already, social media is gonna, if, once the first person learns where this person went, that word's gonna be out. And if, this language protects them if they then out of their volition decide to go there. So I don't have a problem with the amendment as it's written.
Further discussion. Think we're all set?
Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
This is a very difficult vote. I'm gonna have to say no.
Representative Alford? No. Representative Boyer?
No.
Representative Boyer? No. Representative Shamino?
Yes.
Representative Shamino, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
No.
Representative Mastracchio, no. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 7 members of the committee having voted in the affirmative and 3 in the negative.
And the 3 in the negative are,
On to pass, on to pass, on to pass. Okay, thank you.
great, thank
I
you.
don't think there'll be a fiscal note that requires an amendment. There may be a fiscal impact, but I'll double check. So it may switch to OTP just for the fiscal note, but I'll let I'll let you know.
All right, so we'll close the work session on LD 2200. Open the work session LD 2202.
Okay, so this is another notice bill. LD 2202. This is the final bill from the commission seeking to implement one of their recommendations. This was a unanimous recommendation. This was a unanimous recommendation from the commission. It would require a healthcare entity to provide notice to the Attorney General about a pending merger or acquisition. At the same time, the healthcare entity is required to notify the Federal Trade Commission or the United States Department of Justice Antitrust Division in accordance with federal laws and regulation. Under current law, the Attorney General is responsible for enforcing Maine's merger statute, which I attached for you. Under that law, persons are engaged in commerce in the state are prohibited from acquiring directly or indirectly the whole or any part of any other person engaged in commerce in any activity affecting commerce if the effect of the acquisition of those assets may substantially lessen competition or tend to create a monopoly. As drafted, the bill's language is modeled after a Uniform Law Commission proposal, the Antitrust Pre-Merger Notification Act. I attached for you a copy of that proposal. The scope of the uniform law applies to notification of mergers in all industries, but LD 2202 focuses specifically to mergers involving healthcare entities only. I think the commission, wanted to keep the focus on healthcare entities. Under federal law, whether prior notice of a merger is required to the FTC is based on the value of the merger. There are a number of different threshold levels that are in the federal law, and then they've been adjusted annually by rule. The current threshold for 2026 is approximately 133 million, the value of the merger, although there are some exceptions and a number of different provisions in the federal law. But essentially, the requirement would be if the notice is required under federal law, if one of the thresholds is triggered, that at the same time they provide notice to the FTC, an entity in Maine should provide that same notice to the Office of the Attorney General. So one of the things to think about is as drafted, again, sort of used for purposes of the drafting, the definition of healthcare entity that's been used throughout, which is a healthcare entity does not include a nursing facility. So that's one thing for the committee to consider. If you move forward with this legislation, it wouldn't include or trigger notice if it was a merger of a nursing facility that met the threshold to the FTC. The commission didn't specifically talk about the definition or how to define a healthcare entity. Just for consistency in all the bills, I use the same definition. But that's something to think about. There also, you had some testimony about whether this is duplicative or in addition to the federal notification requirement. As drafted, this is intended to require an electronic copy of the same materials filed with the FTC to be filed with the Attorney General. So it's not intended to provide any additional burden, just to sort of require, you know, an additional email to be sent essentially, which provides that electronic copy. Cognizant of the fact that there are going to be, as part of the notice, it's going to require, you know, not only a notice, but some additional materials that might be required to be filed with the FTC. But all of those same materials would go to the Attorney General's office. During the commission's deliberation, information provided by the AG's office when they had a presentation noted that having this specific prior notice would allow an opportunity to determine whether a proposed merger has antitrust implications. Their representative testified that they don't often get there's no mandatory requirement that notice be provided to them. So the extent to which they receive prior notice would be based on whether or not an entity approaches them, and that sometimes happens where someone contacts them ahead of time. They may find out about it from other sources, or they may find out about it through media or other things, but this would be a specific trigger for those mergers and acquisitions that would be reviewed at the federal government level. They'd get the notice at the same time at the state level. The last thing I would mention is that bill, as it's drafted, provides that information provided to the Attorney General by these entities is confidential, with certain exceptions. It does allow the AG's office to share information with federal agencies, with other states, and pursuant to a court order, as long as, you know, the confidentiality of that information is honored. So I would say if the committee does move forward, like we talked about with LD 2201, this would trigger a review by the Judiciary Committee in accordance with their review of proposed public records exceptions. So just noting that if this would be something where you would send a memo to the Judiciary Committee and ask them to take a look at it. It's not inconsistent with other provisions of statute or other types of public records exceptions where information about pending transactions are kept confidential by state agencies until, and the exceptions are also consistent, allowing information to be shared pursuant to court order or with other agencies for law enforcement purposes or other purposes. So I'll stop there.
All right, questions for Colleen? If not, do I have a motion? Representative Boyd.
I'll make a motion to pass.
All right, seconded by Representative Foley. Any discussion? Seeing none. Did you get that, Edna? Oh, you're good.
Thank you. Senator Bailey.
Oh, did you have a discussion?
I just really want to very quickly recognize Representative Boyer for this, since this is this is the last bill for now we're going to be considering from the commission that she co-chaired. And I really want to thank her for her excellent hard work. And these bills are all here as a result of their work. And so I just wanted to recognize her.
Thank you.
I second that.
All right, Edna, now I think we're ready.
Thank you. Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
Yes.
Representative Alford, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Semino?
Yes.
Representative Semino, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 10 members of the committee having voted in the affirmative and 0 in the negative.
Okay, so that will close the work session at LD 2202. And then Colleen, I think you just, can you hold on before you pass those out? Thank you. I think everyone's got everything.
Yeah.
I just have two, for language review. The top one, the orange one is the one I should have brought yesterday, 1890. I emailed that to everybody, but just so you have it for your files and Eddie can add it to the files. This was the bill having to do with certificate of need review and increasing the threshold for establishment of new facilities. There's a majority and minority report, but each amendment, no fiscal impact. So that's LD 1890. That should be on Tuesday's calendar. Whether or not you take it up, but it should be on the calendar. And then the second one is LD 2148. This is just a quick markup of this amendment. This was one of the department bills from the Emergency Medical Services Board. You made two clarifications, so you'll just see a markup here. The first is to clarify that for the member of the board representing municipal administration is clarified to be a municipal fire department administration. And then secondly, there was a requirement for the board to submit an annual report to the Joint Standing Committee of the legislature having jurisdiction over emergency medical services matters. There was a suggestion that include HCIFS committee, and since the split is between like oversight over emergency medical services and emergency medical services licensing, that's the way I've described it, because this is going to be an ongoing thing and jurisdiction changes. So the name of the committee wasn't really appropriate to use like in jurisdiction over a health coverage insurance or financial services matter, because who knows what the name of it will be next time. So added that and then gave authority to either committee to report out legislation based on that annual report. So that's the amendment to LD 2128. That's all I had.
That's it. All right, good work, everyone.
Good work.
We made a lot of progress. Poor Colleen also has a lot of work to do. But our numbers are dwindling, and where we don't have session next Wednesday, we will be having a work session Wednesday coming in at 10 o'clock, but we should be able to get a lot of our bills done.
Absolutely. I hope so. Yeah.
Yeah.
I mean, I think we've talked about this before. I think you really only have one more bill that hasn't been printed that you're expecting to get before the committee, the combination or the two licensing boards. But other than that, I don't expect any new bills that you haven't had a public hearing on yet. So,
So we have our public hearing tomorrow, and then that one bill, once we get
When
it,
it-
that,
and then otherwise
should be it.
you have the rest, yep, of your tabled bills. So I haven't done the numbers in my head, but after today, I think you have less than 10 left. And starting at the beginning of the week, you'd voted 60% of your bills. So I think you're in pretty good shape.
very good. All right. So we'll see you all tomorrow afternoon.